Good evening, all the faculties and moderators as well as chairpersons who have joined this CRIP series, the fifth CRIP series. The topic is perioperative IV fluids, which we are using in day-to-day anesthesia practice. We all are prescribing IV fluids in our anesthesia case scenarios. But then, when we prescribe them, what practical points we are applying? What IV fluids we are using in scenarios like trauma, critical care, sepsis, burns? We have faculties today with us to explain in detail more about it. I welcome Dr. Raksha Kudal, Dr. Prakash Dev, Dr. Naresh Anand, and our chairpersons for this today session, Dr. Lakshmi Kumar and Dr. Hemangi Karni. We have ISA national dignitaries with us. I request our Honorary Secretary ISA National, Dr. Bajwa, to have the opening remarks. Dr. Bajwa, sir, please.
Thank you, Dr. Manisha. It's always a pleasure to come to the class and feel like a student with so many, sometimes the younger generation teaching you and the senior sitting there and adding the pearls of wisdom to your current knowledge. And it's always refreshing to get into these classes. As we were discussing, these type of classes, it's a volume 1, volume 2, volume 3. We can have so many in the coming days also. And many things, as discussed earlier, these are very simple things. But there is a one saying which says it's no use of doing the great things, but rather doing the small things in a great way. And that makes you a polished anesthesiologist, a very refined clinician. So perioperative fluid therapy is always a challenging task. You ask anybody joining the first year PG, second year PG, for that person, a ringer lactate or whatever you call a etastarch or a dextran, whatever, nothing is not much difference to that person unless until you get a theoretical background, a practical background about those fluids, how to administer, what are the comorbidities, what are the challenging situations, what are the dynamics of the body, the pharmacodynamics, the pharmacokinetics of the fluids. So many things are associated with that small bottle of fluid. With a 500 ml fluid, there is a world of science hidden in that water. So I think this is the best way, and we have got the best teachers. And there are so many senior persons here sitting who must have done a lot of work, must have done a lot of research, a lot of experience on these fluids during their practical scenarios or in the peripheries or in the institutions. And their suggestions will also be enriching us during this program. So this is a very interactive discussion. And I think I'm also eager to go forward to listen to this. So Dr. Manisha, back to you. You can start the proceedings from here.
Yeah. Thank you so much, sir. We also have with us our co-program heads, Dr. Manoj Kumar and Dr. Chintala Kishan. I request them for their opening remarks. Dr. Manoj Kumar, please.
Good evening to all of you. I welcome as a program head of this CRISP series to all of you. This is very beneficial for our ISA member, especially practitioner and young anesthesiologist. So very good job by ISA National. Thank you, ma'am. Please.
Thank you, sir.
Go ahead.
Dr. Chintala, sir, please.
Yes, respected ISA National Secretary Dr. Sukhwinder Singh Jit Bajwa is supporting very nicely to Manisha Madam. I congratulate Dr. Manisha Madam to continuing this wonderful events. It is just like a classroom in my days. It is looking like that. So I congratulate once again to Manisha Madam and Bajwa Garu and our Manoj Bhai continuing this. Thank you very much, madam.
Thank you so much, sir. Thanks for the compliment. Let's begin with the program. We have two dynamic academic moderators for this program. Dr. Kalyani, will you share the screen for?
Yeah, ma'am, just
yeah. Dr. Kalyani Nilesh Patil, she is Professor of Anesthesiology attached to Bharati Hospital, Pune. She has received many awards. The most important is Best Paper Award for Scientific Paper Presentation in Maharashtra Conference. She also received awards in essay competition, and she has many publications and is a dynamic faculty in our state as well as national conferences. Welcome, Dr. Kalyani.
Thank you, ma'am. Thank you.
Second academic moderator is Dr. Meenal Chauhan, and I think the whole ICS all over India knows her. She's famous for her singing, and recently she got the Best Singing Award in the Doctors Singing Competition, and she was selected as Best Singer for her Best Music Award for the Uttarakhand state. So congratulations, Meenal. Welcome to this program. Dr. Meenal Chauhan is attached to Metro Hospital and Heart Institute in Haridwar. She is practicing there since 9 years, and she has a special interest in obstetric anesthesia, laparoscopic anesthesia, and she has received multiple awards, including the ISA Proficiency Award in 2019, ISA Yuva Orator Award 2022, and many other awards. So welcome, Dr. Meenal Chauhan, and I
Thank you, ma'am.
I request Dr. Kalyani to continue with the program.
Thank you so much, ma'am. Very good evening to everyone. I would like to thank at the outset all the ISA dignitaries for gracing this 5th session of the CRISP series with their presence. I thank ISA National and all the program heads for giving us this opportunity to be the academic moderators for this session. Dr. Meenal Chauhan and myself will be moderating this session on perioperative IV fluids, which, as Dr. Katikar ma'am and Dr. Bajwa sir just mentioned, that it is a very pertinent topic and which needs to be discussed, as it is a key component which affects the outcome of our surgical patients. So for this, I would first like to welcome our first chairperson, Dr. Lakshmi Kumar ma'am. Ma'am is a professor and head in Department of Anesthesia, Amrita Institute of Medical Sciences and Research Center. Ma'am has been conferred an honorary fellowship in pediatric anesthesia by IAPA. She's a lead in transplant anesthesia at Amrita Institute, and she's been felicitated for being a member of more than 1,000 liver transplants in 15 years. She leads the pediatric anesthesia fellowship at Amrita Institute. Ma'am is an associate editor of pediatric anesthesia, section editor and reviewer of JOACP, reviewer of IJA, and she's a trainer for pediatric perioperative life support. It is an honor to have you, ma'am. I welcome you to this series.
Next, I would like to welcome Dr. Himangi Karnik, our second chairperson for the evening. We welcome you, ma'am, and thank you for gracing the occasion. Ma'am, can you change the slide?
Yeah. I have.
Yes. So, Dr. Himangi Karnik, she's a professor of anesthesia in the very prestigious LTM Medical College, known as SIAN. She has an experience of about 36 years, out of which 20 years almost in neuroanesthesia. And she has been honored with various awards like the Har Gobind Foundation Medical Fellowship. She's a visiting professor in Stanford University Hospital and editorial committee member in various journals, a reviewer for 5 journals, editor of A Practical Approach to Anesthesia for Emergency Surgery, a JP Brother publication. And she's got a lot of publications and book chapters ranging to nearly 40. Welcome, ma'am.
Thank you. Just a minute.
Dr. Raksha Kundal.
Yeah. Now I now welcome our speaker for the day, Dr. Raksha Kundal ma'am. Ma'am is an associate professor in AIIMS, Jammu and Kashmir. She has an experience of more than 10 years and in clinical as well as teaching experience. Her interest is pediatric anesthesia and ultrasound guided regional blocks. She's an honorary treasurer of IPA Delhi and executive member of ISA Jammu. She's received COVID Warrior Award for her work in COVID pandemic, and she has more than 40 publications in national and international journals. We welcome you, ma'am. It's an honor to have you.
Thank you, Dr. Kalyan. Next, I would like to welcome Dr. Naresh Anand. Good evening, sir, and welcome on this very esteemed forum. He is a senior consultant and HOD in Mohandai Oswal Cancer and Super Speciality Hospital, Ludhiana. And he has an experience of more than 20 years with clinical interest in regional and general anesthesia. He is a life member of various places, ISA, ISSCP, RSACP, instructor for PCLS and CCLS, been awarded and honored at different events, has more than 20 to 25 publications in various journals. We are very glad, sir, that you could join us today. Welcome.
It's a privilege to welcome our next speaker, Dr. Prakash Dev. Sir is an assistant professor at AIMS Guwahati, and he has a 12 years experience in the field of anesthesiology and critical care. His fields of expertise are onco-anesthesia, thoracic anesthesia, difficult airway, and critical care medicine. Sir has received Young Researcher Award. He's conducted numerous online and on-site training workshops especially on mechanical ventilation and topics pertaining to the intensive care. He's been invited as faculty speaker and chairperson in many national and international conferences. Sir has publications in various international and national journals, and he's written chapters in 5 anesthesia and critical care books. We welcome you, sir. I now welcome all the ISA members as well who are attending today's session. And we'll now begin our academic session with the first talk of the day by Dr. Raksha Kundal ma'am. She'll be talking on our everyday question, which we have to answer and which we answer subconsciously. How do I choose my intravenous fluids in the OR? Over to you, ma'am.
Good evening, everyone. Dr. Bhatta, with your kind permission, can I share my screen?
Yeah, your course, Dr. Raksha, you can share the screen.
Thank you, sir. Is my screen visible?
Yes.
Yeah.
Yes, ma'am.
So, good evening, dear seniors, my colleagues, and my juniors. Today, I will be addressing to a very pertinent issue, which is how do I choose IV fluids in my OR? So there is huge armamentarium of IV fluids, which we have in our OT, and we often get confused what to give and what not to give. So our aim is to replace the volume, and whereas we do not want to disturb the homeostasis in terms of acid-base balance, electrolytes, and osmolarity. So before I jump to what to give in OT, I want to show you that what led me choose these fluids in OT. So this slide shows the concentration of plasma, sodium, potassium, and various electrolytes along with the plasma osmolarity with respect to the other fluids. So we see that normal plasma, it has 135 to 145 of sodium, 3.5 to 5.3 of potassium, 95 to 105 of chloride, and osmolarity, it ranges between 275 to 295. Now, if we go to the fluids, see all the dextrose containing fluid, they are hypotonic. If we see that the dextrose 5%, 4%, they don't have any, dextrose 5% does not have any electrolytes, whereas the 4% with saline, they all have electrolytes, but because of the dextrose contents, which get metabolized in the body, they are hypotonic. If we look at the normal saline, 0.9%, it has 150 sodium as well as 150 chloride, and its osmolarity is 308. The osmolarity 308 is in the range, so we can say it's isotonic, but this electrolyte composition, they does not match to our plasma. So what is matching with our plasma are these three fluids: Ringer lactate, Hartmann solution, and plasma. They have the range of sodium, potassium, and chloride just around the plasma concentration. So all these are isotonic fluids, as well as we can say that they are balanced crystalline fluids. If we look at the 4.5% albumin, gelfusion, and hemaxil, they are our isotonic fluids. So I want you to understand the concept of strong ion difference. What is strong ion difference? It is the difference between all the major positively and negatively charged ions in the plasma. So SID would be sodium, potassium plus magnesium minus chloride plus lactate. So normal SID is important for maintaining the electroneutrality of the plasma. And if I would say that all the physiological solution, those cause neither acidosis or alkalosis, the SID range should be within 40 to 42 milliculon per liter. So if we see the slide, graph goes towards the negative. if SID goes towards the negative, like the SID is less than 40 and goes towards the negative, then there will be a resultant acidosis. And if it goes towards the right side, I mean the SID is increasing, then there will be alkalosis. So let's put this knowledge into our body now. If we have 1 liter of plasma and we are giving 1 liter of normal saline, we all know that the plasma concentration of sodium is 140 and chloride is 102. And resultant strong ion difference would be 38, which is normal. And we are giving 1 liter of normal saline. So when we are mixing these two, the 2 liter volume in vivo in the body will result in sodium concentration average around 147 per liter and the chloride concentration around 128 per liter, which will result in strong ion difference of 19 liter. Now, what is it? It is towards the left side. So there will be resultant acidosis as well as hyperchloremia because the chloride has increased. Sorry. Now, let's see this slide where we are giving ringer lactate. Okay, again, the constitution of plasma will be same. Ringer, we know we have sodium of 137 millicurie per liter, chloride of 109 millicurie per liter, and lactate, which is a strong anion. So the SID is 0 for the bottom in vitro. Now, when we are giving this in the plasma, the average values become sodium 139, within range, chloride 105, it is also within range, and lactate is not inferring any the effect because lactate is getting metabolized in the body. So SID will be 34 per liter, which is not normal, but it is quite close. So it is not causing any major acidosis. So I will discuss some cases which I have made only for the IV fluid. Please don't take it in some. Like 25-year-old male who is ASA1 posted for lipoma, excision neck. Patient is NPO 6 hours and expected duration of surgery is 1 hour. So I would prefer to give balanced crystallite fluids. By balanced crystallite fluid, I mean ringer lactate or plasmalite. Another case, if there is a 40-year-old road traffic accident victim who has a blunt trauma abdomen and is posted for exploratory laparotomy, then what would be the fluid choice of resuscitation? Again, I don't want him to become acidotic and keep pushing other fluids. So I'll give balanced isotonic fluid and preferably plasmalite here. Why plasmalite? Because plasmalite don't have lactate and also it is not causing a bit of lactose acidosis, which the ringer lactate will cause if it is given in the large volumes. And if there is any blood loss and blood products are required, they have to be replaced with blood. And in the absence of blood or blood product, we can bridge the gap with colloids. If I have a 65-year-old female who is ASA1, 6-hour NPO posted for laparoscopic cholecystectomy, the fluid of choice for deficient and maintenance again would be balanced isotonic fluids for me. In another case, if there is 56-year-old diabetic male who is posted for laparotomy for abdominoperineal resection and is shifted to my OR with a neutralizing drip of insulin in D5, then I would continue the neutralizing drip and I would use the balanced crystallite fluids for the maintenance as well as the resuscitation. And if there is any blood or blood component required, I'll replace them with the blood and blood components only. This was for adults. How do we choose our IV fluids for the pediatric patients? According to the recent guidelines, a healthy children who is undergoing minor surgery and obeying all the fasting guidelines and is expected to resume the orals do not need any IV fluids. And we do not give hypotonic fluids like dextrose containing fluids because they're bound to cause hyponatremia, they increase cerebral edema, raise intracranial pressure and subsequent consequences. Dextrose, as we know, it gets metabolized and all the dextrose containing fluids are hypotonic, so they should not be given to the pediatric patients. So although hypoglycemia is rare in the child, except there are few cases, like in preterm infants, in a neonates less than 48 hours, in a patient who is weighing less than 3 centile, if patient is undergoing extensive regional block, Why extensive regional block? There is no stress, there is no adrenal release, there is no hyperglycemia. So these patients might get hypoglycemia. And if the surgery is continuing more than 3 hours. So what would I choose? I will choose, according to the guidelines, a low concentration of dextrose in 1 to 2.5% isotonic fluid. And it is recommended in all the surgeries which are more than minor. The question is, like, there is no market preparation exists, like which provide us 1% or 2% dextrose in balanced salt solution. So what I do, I make a 2% dextrose RL drip. My process of making is like I mix 80 ml of ringer lactate along with 20 ml of D5 in a 100 ml burette. And if I want to make it 1%, what I will use 19 ml of ringer lactate and 10 ml of D5 in a 100 ml burette. And if you want to make it in a bulk, like in a bigger bottle, if you want to make 1% dextrose ringer lactate, then you can add 10 ml of 50% dextrose in a bottle of 500 ml of ringer lactate. Or if you want to make it 2.5% dextrose, then you can add 25 ml of 50% dextrose in 500 ml bottle of ringer lactate. This is how you make 1% or 2.5% or 2% dextrose solution for the patients. So how do I choose IV fluids in a neonate? Suppose there is a case, 3-day-old premature neonate, which is brought to my OR for the management of intussusception and is on the drip with N/2 dextrose 10% for maintenance. So for neonates, what I do, I always continue the drip. Although I make my drip of own, but I always give the same concentration of dextrose which neonate is on. And for resuscitation, I use balanced crystallite fluid, either RL or plasmalite. And the resuscitation also I will do with balanced crystallite fluid. If there is some neonate who is a 2-day-old and is having tracheoesophageal fistula and came to us for repair and is shifted on N/2 5% dextrose, then again what I will do, I will make the same concentration of dextrose solution for the patient for the maintenance. And for resuscitation, I will use balanced crystallite fluid solution. And if there is any blood loss, then it has to be replaced with blood. And I'm not giving any colloids in neonates. For a case like 3-year-old boy who is brought to my OT for hernia surgery, if he's NPO for solids in 6 hours and was on clear fluids till 2 hours back, then according to the guidelines, there is no need of the IV fluid. So if you wish to give IV fluid, then you can give ringer lactate maintenance dose only for the purpose. Otherwise, there is no need of giving IV fluid to such a patient because he will resume orals as soon as possible. Suppose if there is 2-year-old boy posted for subcondylar humerus fracture repair and he's 6-hour NPO for food and water. So intraoperative fluid of choice again will be balanced salt isotonic fluids for deficit, and for maintenance I will make it 1% dextrose in the balanced crystallite fluid. So if I have to give fluids to patient who is more than 2 years of age, I won't give any dextrose unless or until it is indicated like surgery is getting prolonged. Below 2 years, I always choose to give 1% to 2.5% dextrose for the maintenance along with the ringer lactate or plasmalate. That's all from me. Thank you.
Thank you, ma'am. Dr. Raksha Kundal. This was indeed an extremely enlightening presentation because it is dealing with the chemistry and the most basic topic, and we see here that there are almost 320 participants who have logged in, and a lot of them are postgraduates, and I'm sure they have benefited greatly from whatever you have just told us. In fact, I would like to tell all of you who are watching this that there are a lot of questions which are coming in the chat box. So please let them flow. We are going to take all the questions at the end after we finish off with the entire presentation and keep jotting them down on the chat box. So as ma'am has spoken about RL versus the balanced salt solution, a lot of pediatric cases have also been discussed. I would like to request our chairperson, Dr. Lakshmi Kumar, who is actually specializing in pediatric anesthesia, Madam, would you like to share your viewpoint on whatever Madam Raksha Kundal has just spoken?
Yeah, thank you. Actually, it's just not pediatrics. Fluids has definitely been my passion and an area where I found intriguing because not many of us know the right answer. Some of them still elude us. So I agree with whatever Dr. Raksha has put up in a very nice presentation, and I'm sure it gives very practical insights. A couple of different thoughts. She has very nicely suggested which is a group of children who need dextrose supplementation during surgery. I completely agree with her, the neonates particularly. Now, we need to know what is hypoglycemia in infants, right? It is not the same as it is in adults. And while in neonates, it is about 48 or 52 milligrams. When you cross the 1 month, you look at a value less than 70 as being hypoglycemia and a value more than 150 as being hyperglycemia. So I have a slight difference in the thought that you need to give 1% dextrose completely, because we have done a couple of studies, in fact, more than 2. And we found that if you're going to replace 1% dextrose, let's say for a child who's 18 months, both as maintenance and as replacement for the surgery, you would tend to shift the child slightly in the hyperglycemic range. And this range can be decreased if you add a caudal or a regional block. So if you really want to be, very, very obsessive, what we do is what I did for the study at least was to give only the requirement, the maintenance requirement as 1% dextrose, and any additional losses we gave as plain ringalactate without dextrose. And that keeps the glucose at a very comfortable level of 90 to 110. If you were to give all of the child's fluid replacement as 1%, you will go to 120 to 130. And of course, the argument is what is wrong in that? There is nothing wrong, right? But if you want to keep it really proper, you don't have to give all of the fluid as 1% dextrose. That is the only thing that I disagree. And she said ringalactate in large quantities will cause acidosis. Would you like to clarify that, Dr. Raksha? Because I didn't quite follow that statement. I'm not able to see you now.
Ma'am,
Yeah.
actually ringalactate has SID which is less than the physiological range. So it's not physiological. If we are giving a lot of ringalactate, SID will decrease certainly. So in my view, if we are giving it in large quantity, it will certainly cause some acidosis. So it is wise to give plasma light in situation where there is already hypotension, shock, and some acidosis. That's what I meant. I will prefer plasma light over ringalactate.
I agree. The argument for not giving it in those instances is when a patient is hypotensive or is in shock, he's going to have cellular hypoxemia and lactic acidosis. And your justification is any hepatic ischemia can affect the metabolism of lactate. That argument is okay. I'm not fully convinced about the SID in ringalactate, and I truly have not seen acidosis with giving too much ringalactate. But maybe if there's some situation that you have, particularly like to allude to, I'd like to keep that in mind. I also do not, theoretically, it causes hyperglycemia even in diabetics, but practically we really don't see it. I mean, these are my thoughts on that. Otherwise, I think it's a fantastic lecture.
Thank you, ma'am. Thank you for sharing. And I would actually want to thank Dr. Manisha and the ISA National for coming up with this excellent topic, which is the base of whatever we are practicing. But at the same time, I would like to ask Dr. Himangi Karnik. There are certain people in the chat box also, they're saying that, okay, we choose certain fluids, but, a lot of pediatricians, they just change those fluids or they don't listen to us. So I would also want you to talk about that, Dr. Himangi, and also balanced salt solution versus RL. Yes, Dr. Himangi, please.
Thank you. And first of all, Dr. Raksha, it was an excellent presentation and you described the different options, different situations very well and all. I agree with Dr. Lakshmi Kumar that it's not only just giving glucose. to pediatric patient because they might go into hypoglycemia. It also depends upon what are our targets and in which type of patient what we want. Like I practice neuroanesthesia. So my pediatric practice is for pediatric neuroanesthesia where we don't want hyperglycemia. So in those cases, we probably will monitor the blood glucose level and then give the glucose level only up to the requirement. So that is exactly is the difference in thinking with, as Dr. Minal asked, that the surgeons may want different fluid to be given and we may want different fluid to be given because our aims are different, our goals are different. What we want probably is to have the patient volume replacement and all. What the surgeons or the pediatrician wants it before taking the patient on for surgery are different things. Like one thing that has not been mentioned is the pre-existing electrolyte imbalance. So if their goal is to replace the electrolyte, they may choose differently. So that is why this discrepancy may become common, especially when the patient is coming from the another ICU and going back to another ICU. So intraoperatively, we have our own goals or our own purposes for starting the fluid and all, and that is why the this will change. It is a common practice in our OT that we do not use the fluids coming from the ICU and we prepare the fresh fluids. And similarly, probably while taking over also, they might be doing the similar one when the patient goes into another ICU. So that is probably the thing. Besides, when we say the perioperative fluid therapy, it is not only for fluid replacement. It may be for different reasons. For example, hypertonic saline. It is not only for fluid therapy. Okay, for trauma resuscitation, it may be for fluid resuscitation, but for in an ICU, it may be for cerebral dehydration or for correction of hyponatremia and all. So depending upon what is the purpose, the volume and the choice may differ. And Dr. Raksha used a very excellent word, patients obeying fasting guidelines. This is very nice thing that we need to remember. We know the guidelines that patients should be starving for so many hours and all, but does it actually happens? Are they really taking the clear drinks 2 hours pre-op, or whether the patient is overstarving? So keeping all those things in account, we may have to choose our fluid differently. First, to replace the deficit, and second, to maintain. And she had also given an example of that the patient was overstarving and how the both replacements are done. But we have to consciously remember that whether patients are following those things, guidelines or no. And if not, what is the fluid balance initially, whether we need to give that additionally or no for the oral fluid deficit. And there should not be much of a fluid creep. So
right, ma'am. Thank you, ma'am. Thank you on the pearls which you've just given us. So basically, the entire perioperative fluid therapies is based on this whole concept only, which we'll be discussing further and further. A lot of questions are coming in. We take the next topic forward, where Dr. Kalyani would be discussing 2 very important case presentations with all of us, and then we would take it further from there. Thank you, ma'am. Dr. Kalyani, over to you.
Thank you, Meenal. I would like to thank Dr. Raksha Kundal ma'am for such a explanative lecture and for clearing the concept of strong iron difference, which definitely will help our postgraduate students. And thanks to Dr. Lakshmi ma'am and Dr. Himangi Karnik ma'am for sharing your experience. So we now move on to
Dr.
the
Kalyani,
next session.
Dr. Kalyani, just wait. Don't move forward without clearing the doubts in the chat box. That's a
So,
because
we will take up the chat
No. One session we have to.
Okay, sir.
We will get the question lost in the chat box.
Okay.
Chat box will be full of 100 questions. We will forget everything. Na? People want to get discussion on that part also.
Okay, sir. Yeah.
Discuss those before moving forward, please.
Okay,
okay, then actually there's one question which is being repeatedly asked about Isolite P.
Isolite P, yeah.
Dr. Raksha Kundal, could you just answer some about Isolite P?
Most of the pediatric surgeons and pediatricians, they are still using Isolite P. Isolate P has sodium concentration of 23 and potassium of 26, which is not anyway matching with the plasma concentration. I agree that neonates in the first day of life, they do not need any electrolytes. And after that, they have low load, like their kidney cannot tolerate much electrolyte load. But in OT, when patient comes to us, we prefer that we give them the fluid which is like in the range of the plasma electrolyte values. So we do not give isolate P in the operation theaters.
So can I add a word on this? Can I add a word
Sure,
on
sir,
this?
please.
Sure, sure.
She is rightly telling that nowadays this N by 2, N by 4, N by 6 IV fluids are only used by the pediatrician or in the neonatal units. But as the patient comes to us, we change it. We change it to 0.9% of sodium chloride as the adult concentration, definitely with backup of dextrose infusion, which they are using it in separate syringe pumps and in the separate lines. But we don't use nowadays N by 4 isolate P or N by 6 anymore. Thank you.
At the same time, I would like to ask Dr. Naresh Anand if you would want to continue, that there are questions regarding where all are we going to use 1% dextrose? We have 5%, but where are there any other places where we use 1% dextrose? Dr. Naresh Anand?
1% dextrose we have not used. We have used only 5% dextrose. It is the only fluid which is to be used in neonatal ICU, but not in OR. Operation room, we don't use 1% dextrose. We use 5% dextrose. Definitely we keep on checking if the surgery gets prolonged, maybe for 1.5 hours, even for a neonate it's a long surgery. We check the blood sugar levels and we titrate either with the 5% only. We have never used 1% or 2%.
I'd probably contribute that all neonates need to be titrated with the glucose percentage as is calculated by a nomogram. All neonates will have a special preparation of dextrose along with electrolytes, which is made by adding whatever percentage of dextrose, and the final solution can range from between 8 to 12%. And then they add 3% saline, they add some soda bicarb, they add potassium, they add aminoven, and the maintenance dose for the child roughly will be by the holiday SAGAR, about 4 ml per kg for a neonate. So a 3 kg neonate will be getting 12 ml per hour of this solution. I believe that this solution should be continued in the maintenance dose throughout surgery. And further losses, in the neonate, you can take a choice between either replacing with normal saline or ringer lactate. Any boluses of fluid, according to the loss or how you feel the fontanelle, which is about 5 to 10 ml per kg, should be of these solutions. But the base solution, 8, 9, 10, 11, 12% dextrose should continue. They will get hypoglycemia otherwise. They are being looked after with this percentage dextrose. They will not be able to mount a stress response. Their adrenal is immature. You need to give them dextrose.
Yes, fully agree, ma'am. Fully agree. Dextrose should be given. But I had a query on this. I have a different opinion regarding the lactate, ringer lactate. Already liver is not mature in neonates, and over and above we are giving ringer lactate. When we have the better options available nowadays in the form of balanced salt solution, which is as good as the plasma.
Ringer lactate is also a balanced
salt.
Yeah, but it contains more of the lactates, so the lactate will not be metabolized in the immature liver. That is why it has gone out of the interest of the many people.
Maybe. I don't think it's gone out of interest. Ringer lactate still remains.
Okay.
Since we are on pediatrics, so there are quite many questions on the 4-to-1 rule. Is it still valid or is it obsolete?
I think that's probably meant for me because I had another lecture spoke on this. It is, you can call it however, but you need to, in your mind, know that any surgery has maintenance and losses. You decide whichever formula you want, but you need to give a maintenance dose for the child, which can be without dextrose if the child is older and with dextrose if the child is younger. If you're giving a regional anesthetic, be it a caudal or a block or an epidural or an ESP, whatever, it's likely that the stress responses are muted and the child tends to go to hypoglycemia. So a 1% dextrose may be needed for a long surgery. And the only way that I can calculate is by the maintenance formula of Holiday and Sagar. So you can be a purist and say, I think that Holiday Sagar is not this thing. But you find some other formula that will tell you what the body has to metabolize, and for metabolism, it needs some fluid. How much you want to give a child, whatever formula you want to calculate calorie expenditure or so many ml in 24 hours, do it. But give that for metabolism and any other losses. It can be by radiation, by conduction, by losses. That has to be given as a balanced salt solution without dextrose. So once you have that concept, you give it however you want. And with the same thoughts, a neonate cannot mount a stress response, needs glucose. You need to give that dextrose continuously for a neonate. And any other losses, I give ringer lactate, I give normal saline, both. I have not seen acidosis in these children. The liver is immature, but then even if you give atracurium and cisatracurium, are we saying that the child's not going to come out? We extubate neonates at the end of surgery.
Atracurium is metabolized in the plasma, ma'am. Atracurium is not metabolized in the liver. It is in the plasma.
But so we are also giving vecuronium. It's not like we are not giving that.
Okay, we don't give vecuronium. Atracurium, I agree, is supposed to be non-organ dependent. We also give fentanyl. We also give propofol. We extubate the child at the end of surgery. So the liver is functioning. I have not seen lactic acidosis. And if I were giving normal saline, perhaps that is right. But then you yourself have said that the kidneys are immature, and giving 154 sodium continuously to a child, I would have a little bit of concerns. It could be an independent view. You may know better or you may find it better. But these are my thoughts on this.
So Dr. Lakshmi,
which patients,
I would like to...
just a question to Lakshmi ma'am, Meenal. Ma'am just mentioned she uses normal saline also. So in which patients, ma'am, do you use normal saline? Which pediatric patients? Like any specific indications for using normal saline?
Very rarely, but if you want to know, those that have, vomiting and alkalosis.
Okay, yeah. So where you need to replace the chlorides, basically.
So in those, like the pyloric stenosis, I think there is indication that normal saline may be superior to ringer lactate in one particular group where there's so much of
because they have alkalosis and
so you may want.
Okay.
Ma'am, at the same time, I would like to ask you that there are questions coming that would you prefer RL versus balanced salt solution, or would you be more towards the balanced salt solution?
Also a balanced salt solution.
Yeah.
Plasmalite in the pediatric population is just being researched. I have used it. I've not found any problem, but it has not been tested over years as has ringer lactate.
Ringer lactate has been, right.
And if we are comfortable, it may become thick. But again, there's a bit of a cost difference. And the nature of surgery, you need to take a call as to what are you trying to achieve by giving the Plasmalite, that you're making the sodium and chloride more towards the plasma, fine. And do you really need to give an acetate instead of a lactate? If you can answer those questions in affirmative, then I suppose you can give Plasmalite. But remember that we are just using it perhaps over the last 5 to 6 years, gingerly. And metabolically, I have not found a difference, but maybe something will come, or maybe it will get accepted as a standard practice. I don't know.
Okay, there's a question on German guidelines in pediatric fluid management. Can you please explain?
I'm not aware, but Dr. Himangi,
yeah. Can anyone just...
We can move further if this can be.
There's one.
Meenal, there are still many questions in the chat box.
Yeah. There's one question. Yeah.
Dr. Prakash,
on dilution, which fluid to use for dilution? Because most of the times the diluting volume is more than the requirement of the neonate. So, ma'am, can you just explain?
We use 5% dextrose. Dr. Himangi, you have different.
We use normal saline for that, for dilution. And as far as people saying that normal saline is bad or ringer lactate is not bad or things like that, it is not the absolute fluid which is bad. The example that was just given is almost 50% of the blood volume. If it is replaced, then that much acidosis develops and things like that. So it was an extreme example that was given. If you are using some, whether it is a normal saline or ringer lactate in a limited quantities, then it is not bad, or it is not going to make gross difference. Some of the drugs needed to be diluted in distilled water. Then they dissolve better. So for those drugs, it becomes important that we use distilled water. Otherwise, I use a normal saline for dilution. And there are no such guidelines that you should dilute in this particular agent or like that.
So I have 2-3 questions together for Dr. Prakash Deb. Sir,
Doc-
could you please
Dr.
tell
Menon,
us-
Dr.
Yes,
Menon,
ma'am. Yes,
Dr.
ma'am.
Prakash Dev will be answering the questions after his
After
talk.
his talk.
We
Okay,
have
okay.
two,
So we'll have this only.
chairpersons,
Okay,
senior
okay.
chairpersons. So if the queries are not solved by, and also Dr. Raksha Kundal, so
Yeah.
ask them to solve these queries.
So Dr.
Mhm.
Raksha Kundal, if you could just tell us about the fluid of choice for sickle cell disease.
For sickle cell disease in like
Yes.
adult patient?
Yes,
It's
this
not
is for adults
specifically
now. The
mentioned, but we
next
can
is for,
discuss in adult.
yeah, we can discuss.
Okay, again, I would like to give only balanced crystallite fluid in sickle cell patients. So if I have plasma light, I will prefer plasma light over ringer lactate. Otherwise, both can be given.
Okay, and what about fluids to be given for CKD patients?
I can answer that.
Yes,
So,
ma'am,
are
please.
you talking about adults or children?
Both,
Adults?
ma'am, you could take anything. Yes, ma'am.
So CKD patients, I'm sure Dr. Himangi would also. There are studies that have compared normal saline and ringer lactate, and they found that when they gave normal saline to CKD patients, there was more hyperkalemia because of the acidosis, right? So we have a policy that if the potassium is less than 4.5, we give a balanced salt solution, preferably plasma light, because the CKD patients we see usually are coming for transplant. If the potassium is more than 4.5, then we make that concoction of half normal saline with soda bicarb, and that's what we use. So I think it is a safe policy. It will also let you know that you need to be vigilant with giving potassium to a CKD, and also important that you need to have a base. So you either give the base as RL or plasma light or as half NS with bicarb. So in both you give a balanced
Bicarb, yeah.
Dr. Kalani, could you take 1 or 2 questions?
Yeah, so there are a few questions on obstetrics basically, especially in PIH and gestational diabetes. So Dr. Himangi Karnik ma'am, can you please take up the questions?
In pregnancy, there are no such different choices of the fluid. We can use any of the drugs, any of the fluids, that is whether it is normal saline or ringer lactate, or probably both alternately also is the routine choice for all these years. But nowadays the preference is towards using the balanced salt solutions, that is the plasma light or Kabi or that is there, and which can be used typically most of the patients.
Okay, ma'am. There's one question in, yes, Dr. Meenal, you want to ask anything?
Yes, you ask, ma'am, please ask.
Yeah, no, I'm going to the next question. So should we move ahead?
No, there's one more question actually, which says about the, so I would like Dr. Lakshmi to please take up this. There's a lot of thing between the restrictive fluid therapy and the liberal fluid therapy. So there's a question on the chat box regarding the fluid restrictions. Could you please enlighten us, ma'am, about that?
So I think over 10 years, 15 years, we've evolved from pushing in fluid to get the blood pressure up and learning to restrict with the use of vasopressors, knowing that minimal doses or even up to 0.2 mics of vasopressors doesn't really harm the outcomes. So if you were to look at laparoscopic surgery, a restrictive would be about 2 ml per kg per hour. And if you're looking at an open surgery, perhaps it is like 4 to 5 ml per kg per hour. In both sets of cases, you need to look at key things. 1 is a mean arterial pressure, 2 is the urine output, 3 is a lactate. If any of this comes low, you need to first give fluid. If you don't find a response, now the fluid before we used to give 500 ml, now it has come less. The boluses are only 250 ml. So 1 or 2 boluses. And if you don't have a response, I would definitely add that norepinephrine. If there is no output, despite giving 1 or 2 boluses of fluid in an open surgery, I have a tendency to give a small dose of diuretic. I find that helpful, and I do not believe it has caused harm. In fact, after prolonged laparoscopic surgery, I feel it helps in extubation. this is my personal experience. I don't know about science or literature. But then having asked this question, this is what I would do. I'm very, very, very obsessed about maintaining that urine output during surgery.
Yeah. Ma'am, there was
Can
an
I add a point?
relief
Can I add a
trial
point?
which Lakshmi Kumar
Or
ma'am.
restricted fluid therapy, can I add a point on this?
Yes,
Sure,
Yeah.
sure, sir. Sure.
Actually, this restricted fluid therapy is a modified version of goal-directed fluid therapy. It is
Yes.
more helpful when you have the advanced hemodynamic parameters in place. Like
Yes.
we had the flow track in use where you can assess beat to beat cardiac output, stroke volume, the cardiac index. Then it can be better and more accurately given to the patient rather than we are giving in a clinical scenario with the regular conventional monitor. So it is better to have a flow track or advanced hemodynamic monitor when we are giving restricted fluid therapy.
Which is important, sir, for assessing the fluid responsiveness, which is what you want.
Yes.
May I add a point?
It is very good. It is very good. Excellent in long duration surgeries. Flow
How
track
we can,
is
check
excellent.
the stroke volume and how
Yeah, beat to
the
beat.
blood
It is
pressure and the
beat to
stroke volume can be
Yeah.
managed. Right.
So may I add a point, Minal madam?
Yes,
Yes,
sir,
sir,
please.
yeah.
Yeah. So regarding liberal and restrictive fluid therapy, so this has been a point of controversy for a long period of time.
Yeah.
So ideally, it has to be euvolemia and adequate maintenance of perfusion, oxygen delivery has to be adequate at the organ level. So as Lakshmi madam said that she measures the urine output, she is
Urine
comfortable
output.
when the urine is pouring. So like that, there are different other organs which we can assess clinically, and it has to be added with other physiological variables, like if we have the dynamic parameters instead of the static parameters in hand, because these are not feasible in every cases. So we have to
Yeah.
mostly depend on the physiological parameters. If those parameters are there in hand, like non-invasive or invasive cardiac output monitoring indexes, and you can use fluid
Correct.
challenges also if required. So these are more important. And one important point is that it has to be dependent on the type of anesthesia we have given. So suppose you have given spinal anesthesia, you have already loaded the patient and you know hypertension has happened, the next step should be a vasopressor, small dose of methamphetamine. Like if you are using flap surgeries, so you cannot go on increasing your vasopressor because this will hamper the graft vascularity. So those small things like thoracic patients, it is rather you have to be on the
Yeah.
restrictive side rather than going
Restrictive
for
side.
a accumulated fluid balance more than 1 to 2 liters over 24 hours. So all these things have to happen, but at the same time our prime target has to be the DO2. The oxygen utilization is happening at the tissue level. If we have more advanced these things which are usually not present in the OT setup, we can use lactate or base excess, all those things. If these are not biased by other factors intraoperatively, so you can use those also to know what is
So
happening at the
basically, sir, it is
microcirculation
not
level.
just the blood pressure which we are looking at, we're also looking at the
Right.
flow. The
R-
flow
right.
is also very
different
important.
Flow, and also if you have SCVO2 and lactate and other things, it can actually help you understanding how your oxygen extraction is happening at the tissue level. So that would help you.
Now that you've spoken about the fluid challenge, would Dr. Himangi Karnik, ma'am, would you want to tell us a little bit about the fluid challenge also here?
Yeah, as you just now said that it is not only the pressure which is important, it is also the flow. Different organs function at a adequate flow and pressure, both are required. So that is where the whether we can give the fluid challenge and all to improve the function or no comes into the play. So now goal-directed fluid therapy has become a norm in most of the complicated cases, like the patients with which are having a high risk patient because of the comorbidities. Also, again, goal-directed therapy is required. Whether the surgical risk is high, again goal-directed. But if the patient risk is less, then every patient we cannot take flow track or invasive lines cannot be taken and all. So in those cases, the only dependence thing. Only thing that we can manage, we can check is the fluid challenge and whether a patient becomes more stable blood pressure wise or no. Only fluid challenge without invasive thing, you cannot know the organ perfusion. So when goal-directed fluid therapy is being used, then you see the you give the 250 ml of crystalloids and all and see whether the PPV has come back to the acceptable range or normal range or no. Earlier, the fluid challenge used to be a larger volume, But now it is said that as low as even 100 ml of fluid, also you will be able to identify whether patient is fluid responsive or no. Another thing that has come up recently is a simple test of passive leg raising also can be used as a fluid challenge, and simply raising the legs, if that is bringing your SVV or PPV within the acceptable range or so, that also means that the patient is fluid responsive, and that can be used to provide the increased volume or that much. This
So,
becomes more important when the patient is at the risk of overloading or the cardiac risk is high. So you don't want to give too much of a fluid and only want to restrict. So in those cases, passive leg raising also might be used, or small volume boluses can also be used.
So, ma'am, here the end goal is to have an increase in MAP by 10%, is it? How much
Something
are we looking
like
at? Okay.
Something like that. But then when you are giving the vasopressors and all, then blood pressure alone cannot be your target point. So better to have the, in those type of cases, at least you can have the pulse pressure variation, stroke volume variation, one of the two can be used for that.
Dr. Kalyani, could you take a few questions?
Yeah. Thank you, Dr. Meenir. So there's one question. Can we give mannitol in pediatric patient having cerebral edema? Dr. Lakshmi Kumar, ma'am, can you just answer that?
Yeah, why not? Why not? You just need to calculate the dose, 0.5 or 1 gram per kg body weight, 20%. So about 5 ml is 1 gram. You can give.
Yeah.
I think the condition is bleeding when you would be cautious. I don't do too much of neuro anesthesia, so I'm not sure. But why not? We give it for children with acute liver failure with cerebral.
Okay. Dr. Himangi Karnik, ma'am, do you agree? Like in neuro anesthesia?
Mannitol can be given, and we are regularly using it for pediatric patients. However, quite often the very small babies which come for this neurosurgeries, they are usually big hydrocephalus patients, and also there is hardly any brain tissue to constrict. So in those cases, probably the mannitol can cause even diuresis, and because of that, hypovolemia risk is high. So the choice, by choice, pediatricians or in pediatric ICU, the preferred drug is the hypertonic saline, which does not cause hypovolemia. So both the drugs, hypertonic saline as well as mannitol, can be given, but you need to know the plus and minuses of each drug and use it properly and not in very high doses or very fast.
Himangi ma'am,
thank you so much.
Shall I add one thing, Himangi ma'am?
Sure.
Ma'am, regarding this mannitol in pediatric patients, I think there are certain factors also. Why not using glycerol? I think when the cerebral edema is there, I think that is much safer also, rather than the fluid loading with the mannitol. We have to decompress the basically edema part. Sometimes the fluid comes a little bit overloading is there with the mannitol. We can always go for the glycerol also. It's going to do the same function.
Oral glycerol.
Oral glycerol, ma'am.
Oral glycerol can be used, but overall the efficacy is less and it takes little time for the correction. So that is why it is not much liked by the neurosurgeons. But it can also be used. Usually we change over to oral glycerols after 4 days of mannitol therapy or after the patient's devices.
Suppose a pediatric patient has got some renal involvement also, then we have to switch over to the glycerol, I think. If the patient is developing some renal complications because of suppose any head injury or some edema also, simultaneously the renal tissue is also involved. I think we should go for glycerol. Then it is the best alternative.
Only problem with pediatric patient is with head injury is that they are having persistent vomiting because of raised ICP. So giving oral drugs is a problem in these patients in this group of patients. I think Dr. Kalyani, if there are can we move on to the second
to the next session? We can
Actually,
take
ma'am,
the
there are
remaining
about
questions
20
later.
more questions. We'll take it later.
Yeah, is that fine?
Yeah, please.
So now we'll proceed to the next interactive session, cracking the scientific dilemma. So it's pretty much clear from the discussion which we had now that perioperative fluid is one of the most debatable and contentious topic in anesthesia. And despite significant research, there still is a wide disparity over the preferences of different clinicians, whether to use a colloid or a crystalloid, a balanced or unbalanced salt solution, or a liberal fluid therapy versus a restrictive fluid therapy. So to begin the discussion, I'll just be sharing two cases which I conducted recently. So I'll just share my screen for the presentation. Is it visible?
Yes, ma'am.
Yeah. So the first case is of traumatic brain injury, a 43-year-old male who presented to the emergency medicine department with alleged history of assault with a sickle. He had 2 to 3 episodes of vomiting followed by altered sensorium. He had to be intubated in the emergency department in view of dropping GCS. The emergency CT scan showed linear depressed fracture of the left parietal bone, along with an SDH of 6.2 millimeters crossing the midline, a mild subarachnoid hemorrhage in the frontotemporal and parietal region, with medial uncal herniation and a midline shift of 2.2 millimeters towards the right. And he was now posted for emergency decompressive craniotomy. And the second case which I did is an emergency exploratory laparotomy in a 67-year-old female who's a known case of diabetes and hypertension with perforation peritonitis. She presented in the EMD with tachycardia, hypotension, and cold extremities. The ABG was suggestive of high anion gap metabolic acidosis, and her lactates were raised. She was started on a noradrenaline infusion once she was shifted to the ICU, and she was now posted for emergency exploratory laparotomy. So these are the two cases which I did, and I would like to continue to the discussion. Yeah.
Yes. So, ma'am, could you put the first case? So, Dr. Naresh Anand, if you would like to talk about the first case where there's a traumatic brain injury and what is the perioperative fluid management which you would like to use.
May I interrupt here?
Yes, ma'am. Sure.
Do you mean 2.2 millimeter midline shift or 2.2 centimeters?
It must be centimeters.
Yeah, centimeters.
Because the patient has come for this. Yeah.
Sorry.
Dr. Meenal, let Dr. Naresh Anand have his presentation first, and then we will discuss these cases at the end.
Okay.
Let him have his presentation.
Fine, Dr. Naresh Anand, could you please then present your case?
Thank you. Can I start my screen sharing?
Yes, ma'am. Yes, sir.
Yeah, yes, sir. Yes.
I hope it is visible.
It's just starting, sir. Yeah.
Good evening, everyone.
Sir, make it full screen.
So, yeah. Good evening, everyone. Is it visible?
It is visible. Make it full screen.
I made it full screen. I'm not very good tech savvy.
Sir, on the right side, there's a big box there. You can just click that. It's going to come as full screen.
So just on the left side of 68%, you can click.
Yeah.
Down there's an icon which
right
is made
side down.
something like a TV icon or something like that. Dr.
Just on the
Naresh?
left side of 68%, you can just click on the icon on the left side of 68%.
It is full screen on my here. Below here.
Move the second side. Move the
Can you
second
change
slide.
the slides? Yeah.
Is it visible?
No, it is not visible. I think you have logged into the different window. You'll have to again start sharing the screen. Stop sharing and again do that. Share the screen where we all are visible. Share the screen.
Okay. I have minimized it, I think.
Yeah, you have minimized it. Share the screen where we all are visible. Stop sharing first.
Okay. Stop sharing.
Now share the screen where we all are visible. Yes. Excellent.
Is it visible now?
Yes.
So good evening, everyone. I will start off before it goes away because I'm not very familiar with this computer management. So thank you, the organizers, Dr. Bajwa and Dr. Meenakshi, for inviting me for this, giving me an opportunity to present this case. Sorry, this topic. So perioperative fluid therapy, I will go directly to the practical points. A lot of discussion we have already done. Base has been made by the Dr. Raksha. So why we need the fluids? What is the need of fluids in the perioperative period? It is to maintain the hydration of the patient, to maintain the electrolyte balance, to keep the sugar levels within control, and to ensure adequate tissue perfusion. So we have crystalloids, colloids, blood products, and balanced salt solutions. So a bit few, this is a bit crumpy slides. It is only one or two which are so crumpy. The crystalloids are, they are mainly sodium chloride. They are mainly sodium solutions which get diffused freely from the intravascular to the interstitial compartment. Only 25% of the fluid crystalloids stay in the plasma volume, and rest of the fluid gets transferred to the interstitial fluid. So in place of increasing the intravascular volume, they increase the more of the interstitial volume. They are isotonic saline, ringer lactate, barrel salt solutions, and hypertonic salines. While on the other hand, colloids are large molecular weight solutions which stay into the circulation for more time. Means they stay into the plasma, increase the intravascular volume, and they transfer late into the interstitial space. Apart from increasing the intravascular volume, they also increase a bit of the oncotic pressure, which helps to retain the fluids within the circulation. Definitely, it is of help in maintaining the tissue perfusion, but it has a drawbacks also, which we shall be discussing in the coming slides. So colloids which we are using is starches, gelatin, dextrans, albumin, and blood products. Gelatins are earlier to be introduced, but they had some allergic reactions, so they have been overcome by the starches. Nowadays, we are using most of the time starches. So this is a slide which shows difference between the crystalloids and colloids. Crystalloids are low molecular weight. They can be isotonic, hypotonic, or hypertonic. They increase the hydrostatic pressures. They pass through the semi-permeable membrane and stays into the circulation for only 30 minutes. While if we compare on the other side, colloids, they are high molecular weight, hypertonic, increases the colloid oncotic pressure also to some extent, and they do not pass through the semi-permeable membrane very easily. Expand the plasma volume, stays into the circulation for a longer time, around 2 hours. This is the old ratio which has been mentioned here, that 3:1 ratio compared to the colloids. But nowadays it has been replaced is 1:1.5. Now it is not 3. हम लोगों को पहले बोलते थे कि 1 यूनिट अगर आपने कोलोइड दिया है तो आप it is equal to 3 units, but now it is not like that. It is 1:1.5. We will discuss in the discussion part if there is some different version. Crystalloids have rare allergic reactions. Their principle increases the interstitial volume and causes edema, does not interfere with the blood grouping, clotting, or coagulation, and they are easily to be given in the renal failure settings. They are cost effective also. But on the other hand, if we go to the colloids, their allergic reactions are common. As I told, gelatins were out of the interest because of their severe allergic reactions. Even we had seen anaphylaxis with the hemaxil, which was the, I think, first colloid which was introduced into the practice. Then they reduces the cerebral edema, the pulmonary edema, and dextrose interfere with the coagulation parameters, and they interfere in the clotting. So now, why we want to give IV fluids? Which type of, how we decide that which is the time to give IV fluids to maintain its adequate hydration? One is to compensate for the deficit fluid. or we are also calling it as a fasting fluids, for the maintenance fluid, and for the replacement fluid. So deficit fluid is calculated, as we all know, this is an age-old formula, everybody of us knows, but how to give it, many of the new anesthetists or the residents, they make a glitch of it. They do it wrong calculation. Till now, we are using our residents to calculate till they pass out from the their residency program. And I promise you, I tell you that if you ask a third year resident also, he will also make a mistake of it. It is deficit fluid is fasting fluids, which is maintenance into number of hours of fasting. 50% should be given in the first hour, then 25% in the next hour, then 25% in the next hour, whichever fluid is used. This is the fasting fluid, replacement of the fasting. Then maintenance fluid is same formula, 4 ml per kg for the first 10 kg, 2 ml per kg for the next 10 kg, and 1 ml per kg for the rest of the weight of the patient. This we are using it in pediatric age group also, and for the adults also. It gives a very reasonable calculation values to maintain the hydration. Definitely it is not the formula which gives you the value. It is the other parameters also which you should look to see for the adequacy of the fluids. I will tell you the next slide how we maintain collectively overall, whether we are giving the right fluid or we need to change our strategy. Third category is replacement fluid. Replacement fluids means loss of fluids, means blood to blood. It is commonly said that blood should be replaced by blood, but we start replacing the blood when there is more than 30% of the total blood volume loss. Then only we start. For the first 10% of the blood loss, we replace it with the crystalloid. Next 10% is with the colloid, and when the loss increases more than 30%, then we give the blood. Here we have PRBC, that is packed cells, which is better tolerated, which increases the blood volume, which increases the better perfusion, and leukodepleted cells. If it is available leukodepleted cell, then it is good. Nowadays, the trend is use of leukodepleted cell, because I am working here in a cancer institute. I just joined few weeks back. There I have seen that they are using leukodepleted cells to prevent the allergic reactions. They are quite good, but bit costlier than the packed cells. Then replacement fluid, second is coming urine output. We have to ensure during the intraoperative period, when the long duration surgeries, a minimum of 0.3 to 0.5 ml per kg per hour of urine output. 0.3 is a critical limit, but if the patient is having a good renal function preoperatively, he does not have any much comorbidities, patient is well preserved, then we can take a chance to take the urine output to 30 ml per hour. But if it is up to 50 ml, then that is good for the organ perfusion. And then the third space loss. Third space loss is means to say when there are mild surgeries, some small surgeries where the loss is less, like in craniotomies, like in eye surgeries, like in incision and drainage surgeries. There you can give 2 ml per kg per hour. But for the major surgeries like abdominal, thoracic, and especially bone surgeries, peripheral surgeries, pelvic surgeries, there you can replace it with 8 to 10 ml per kg per hour. And definitely it makes a difference to the organ perfusion. Then the loss through the respiratory gases, because we are giving dry gases. All our gases are dry in nature, so they make the mucosa dry. There is loss of fluid from the mucosa. These to be replaced with the IV fluids given to the peripheral lines. Then OT lights, when the patient is though we have kept the temperature, we try to maintain the temperature, but still patient is direct under the OT lights. So they cause loss of heat by evaporation. So I think, I may be wrong in that. I think one of my colleagues has said in their presentation that nothing, no IV fluid is given during the surgery. I think maintenance fluid should be given to all the patients, because this insensible loss is the culprit of poor fluid management. Many people they count this insensible loss to 2 to 3 ml. Some people say there is no need, but as per the books, as per the literature, it should be replaced and it should be taken care of for a good patient out. Now, indicators of adequate. So we have calculated for a 70 kg patient, we have given maintenance fluid uska dekh liya, fasting status dekh liya, but still how we can ensure that the IV fluid is sufficient. So you see it collectively. You see it collectively. Don't believe on the monitor. Do not believe on the your assistants. Believe on the patient. Believe on the patient condition. Believe on the disease of the patient. How believe on the organs of the patient. How they are responding to your treatment. Surgeon will not tell you patient is sleeping and it is the only his organ functions and your clinical acumen and your alertness and your activeness, that how the fluid is making the difference to the patient, whether patient is going in the right direction or patient is going needs some corrective therapies. So these are the parameters which you can evaluate simultaneously to see your treatment. Here treatment is not only done in the OPD, it is done in the operation theater also. So how you see your treatment, you are treating your patient. Make sure urine output is 0.3 to 0.5 ml per kg per hour. Heart rate is 80 to 90. I wrote it thinking that normal patient is maintaining preoperatively also this much, but try to maintain it to the preoperative level. Maintenance of the blood pressure without inodrops. Maintenance of EtCO2, it is a very good parameter. And tidal carbon dioxide is the first parameter which falls down when there is a hypovolemia. You will see your patient is going for abdominal surgery or thoracic surgery, everything is fine. All of a sudden you will see your EtCO2 will start coming from 35 to 42, 27, 28. The graph is going down. You will check everything. Oximetry is all right. Heart rate is all right. BP is all right. But CO2 parameter is one of the first indicator which can wake you up that patient is behind fluids. Then other physical parameters, though the patient is under drapes, you can still pick up the drapes. You can see the color of the skin. You can see the graphical representation of our parameters. Then in pediatrics age group, if it is feasible, you can see the capillary filling time. Either you can, even though again the question is the patient is with the drape, you can check it over the fingertips, nail bed, or ear lobules. That will give you an idea in the operation room that your capillary filling time is more or it is normal. So it is the collective parameters, it is the collective approach which should be followed for decision making of the ट्रीटमेंट ऑफ द पेशेंट. ऐसे नहीं है कि एक हार्ट रेट बढ़ गया तो फटाफट 500 ml फ्लूइड. दिस इज व्हाट इज अ कॉमन स्ट्रेटजी. आई टेल यू, अभी आई हैड अ वेरी लिटिल एक्सपीरियंस इन वर्किंग, बट आई हैव ऑब्जर्व्ड दिस. पेशेंट का हार्ट रेट 80-90 चल रहा है, 120 हो गया, as your assistant will suddenly increase the, sir 500 ml दे दिया. तो यार 500 ml क्यों दे दिया? सर हार्ट रेट बढ़ गया. पेशेंट इज गेटिंग लाइट, पेशेंट द पेन कुछ कंट्रोल नहीं हुआ, पेशेंट इज अंडर द ड्रेप्स, वार्मर लगाया हुआ है, वो चीज नहीं देखी, बस हार्ट रेट बढ़ा, आई फ्लूइड्स. सो ट्राई टू थिंक फॉर 5-10 seconds के what is the reason of this change in the sudden change is the parameter. There are number of factors which shall be contributing to that. You have to filter them one by one, then you will reach to the correct diagnosis. So if you have put a arterial line, then definitely the ABG can help out. And I forgot to mention here the flow track. The flow track is a very good indicator monitor to help you for the long surgery. I again tell you, it is a costly repair. The monitor cost about 4 to 6 lakhs, and the lead every time it is a single disposable lead. It every time it costs 12,000 rupees. 2-3 years back it was costing 12,000 rupees, maybe without GST, and with GST it comes around 15,000. So a patient is going, the surgeons and the management will cry for this. But it is a very good monitor. If the surgery is extensive, the surgeon is a senior person, or he is doing GI surgeries, thoracic surgeries, extensive one, then he will definitely support it. But here you will get a good chance to correct the things B2. Now this is the types of fluid which everybody knows is the same story for crystalloids, colloids, balanced salt solutions, blood and blood products. Nowadays, balanced salt solution is the cup of tea of everyone. I think most of my colleagues and most of my seniors, teachers are using this balanced salt solutions. They are cheap, they are easily available. This is the repetition of the slides. And this is the colloids, starches, gelatins, albumin, and dextrans. So ringer lactate, plasma lite A, capilite A, and volulite. Ringer lactate मैंने बहुत कम यूज किया है, क्योंकि जब तक हम लोग प्रैक्टिस में आए थे मेरा ख्याल बैलेंस सॉल्ट सॉल्यूशन का जमाना आ गया. So that is why practically seeing, still I use it because in ASA 1 or 2 patients, like in pregnant patients who come for the cesarean section, उसमें मैं use कर लेता हूँ. But because of the theoretical risks associated with lactic acidosis and this and that, so we had a better option. So we are sticking to this plasma, this balanced salt solutions. They are cheap, physiological, better tolerated, and easily available. अभी इनके भी price काफी सस्ते हो गए हैं, as good as the ringer lactates. But still, anybody is fine with the ringer lactate? No problem, no problem. Now, blood and blood products. We have whole blood. There's so many options. We have PRBCs, packed cells. We have leukodepleted RBCs. We have fresh frozen plasmas, PRP, SDPs, and coagulation factors. Whole blood is whole blood is nowadays, I have not seen into the other places, many places that it is being used because it increases the plasma volume, unnecessary transfusion of the other cells, other like WBCs, platelets, calcium, then it causes more of the allergic reactions. Not very well tolerated by the patient. PRBCs are nowadays used in most of the hospitals. They are cheap also, that is cost effective also, availability is not an issue also. Leukodepleted cells, I think it must be in the cancer institutes. FFP and PRP, they have specific indications. Please don't advise FFP for thrombocytopenic patients. I have seen people are giving FFP in a patient who have thrombocytopenia. FFP does not have any role in giving correcting the thrombocytopenia or bleeding due to thrombocytopenia. Only they have role when there is a DIC, only when there is a definitive indication. So because FFP is also a costlier affair, and the biggest disadvantage of FFP is once it is being thought, once it is being prepared, you have to use it. You cannot say no, you cannot send it back to the blood bank. And there is lot of there is lot of form filling for sending back to the FFP, and because they are costlier, everybody will cry at the last end ke doctor sahab kyun manga liya jab nahi use karna tha. So make it sure, please talk to your consultants before deciding the blood and blood products. Already we are having shortage of blood and blood products in the society, in the hospitals. So whenever you use it judiciously. Try to avoid it. Please go through the recent guidelines for blood transfusion. I tell you, yesterday, I will not name the surgeon and I will not put a question mark on his IQ or on his competency also. He has given a blood transfusion to a patient for hernia surgery with a hemoglobin of 8.5 grams. The reason told, he did not discuss with us. The reason why we asked why you gave the blood transfusion, he said it was prepared. Patient was telling कि मेरे को ताकत चाहिए, डॉक्टर साहब एक ब्लड भी लगा देना, मेरे पास ब्लड पड़ा. But this kind of pictures you will feel into your practice. So if you cannot refuse it, then just ignore it. But in our practice, we don't follow these things, and we use these things very judiciously. So coagulation factors again very costly. It's very 20 to 22,000 rupees one pack. PRP, SDP, PRP are easily available, but of you can say placebo use, hardly one PRP increases 2 to 3,000 platelets, while SDP increases approximately 50 to 60,000 of platelets. So better for thrombocytopenic patients, don't use it. But here also a question: all thrombocytopenic patients don't bleed. All thrombocytic patients are not. All thrombocytopenia is not a contraindication for surgery. Be liberal, be open, don't get afraid. Don't get afraid of doing a surgery with the patient having a platelet count of 45 to 50,000. If a patient is having a liver disease, CLD patient में आपको इससे ज़्यादा मिलेगा ही नहीं. 45 to 50,000 अगर platelet count है CLD patient का, आप आराम से करा सकते हो. Patient bleed भी नहीं करेगा. Patient का आपको एक 10 ml भी bleed नहीं होएगा if the surgeon places his hand safely. So second thing is, if you have a thromboelastograph, if you have a tag machine in your hospital where you can, to a thrombocytopenic patient, you get a tag done, and if tag is normal, it means count does not matter. So better to take the wiser decisions. If a patient is having low platelet, try to find out the cause for low platelet. If still you are in doubt, go for tag. If tag is fine, then don't worry. No need of PRP, no need of SDP, no need of whole blood. So go ahead with the surgery. Or you can talk to the gastroenterologist. CLD में हमने देखा है लोगों ने CLD पेशेंट कितने सालों से चला आ रहा है, उसका प्लेटलेट, उसकी हिस्ट्री नहीं रिव्यू करी, मिस्ड इट समहाउ. Our non-anesthetist friends, they transfused 2 units of SDP. This is, I am talking practical things. As because Dr. Bajwa ने जब मेरे को बोला कि नरेश इसके ऊपर you prepare the slide. So I said immediately कि ठीक है, I will share a few things with everyone. एक बंदे ने नॉन एनेस्थेटिस्ट बंदे ने 50 to 56,000 उसका 60,000 प्लेटलेट्स है, CLD का पेशेंट है, ठीक ठाक चल रहा है पेशेंट. वो कोई माइल्ड को लैब कोली के लिए आया कि सर्जरी के लिए आया. He transfused 2 units of SDP before the surgery and made the platelets count 1,25,000, which was not required at all. 20-25 वहां पे उसके लग गए, which was not required. Unnecessarily blood products complications and transmission of reactions, allergic reaction, transmission of diseases, so many things happen. So better think coolly, think calmly, think judiciously, because surgeon and surgical colleagues don't go into the medicine part. They stopped reading the medicine. That is why anesthesia has become the perioperative physicians. So
Excuse me, sir. So can you please wind up? Like
okay.
Yeah,
okay.
2 more minutes maybe. Yeah.
Yes. Okay. What fluids? So what fluids? So for deficit fluid, for maintenance and for resuscitation, go for balanced salt solutions or with or without colloids. What we are protecting it, we give balanced salt solution if the intravascular volume is not maintained. If the vitals don't maintain, we give some small amount of colloids, and then we shift it to the crystalloids again. We balance, we maintain the balance like that. Then for replacement fluids, the first choice is balanced salt solution, crystalloid, colloids, packed cells, blood to blood, and albumin. Albumin has a very specific indications. Patient is having liver disease, patient is under a major surgery, malnourished patients, all those patients need albumin. If you want to give as a colloid, use 5% solution. If you want to give as a supplement fluid, then use 20%. It should be given in infusion 10 ml per hour. So for critically ill patient, malnourished, liver disease or cancer disease, use albumin and balanced salt solutions, FFP, PRP, SDP, recombinant factor as per the condition of the patient and lab parameters. Here comes the pediatric patients. I have made a very small slide of pediatric patients because later on I realized I did not make it. We are using 0.9% sodium chloride with 5% dextrose. We are not using N by 2, N by 4, N by 6 because of the neurological damage which occurs with this use of hypotonic, hyponatremic solutions. So we have avoided using it because patient stays with us for a smaller time, for 1 hour, 1.5 hour surgery is a major surgery for the pediatrics age group. So we stick to 0.9% sodium chloride and 5% dextrose. But definitely we follow these things. We preferably give it with the help of infusion pumps or micro drip sets or normal drips. Normal drip set is used for the younger adults, means more than 5 years, more than 8 years. For that we use normal drips. Otherwise we prefer infusion pump or micro drip sets. Thank you. I think it was the last slide. Sorry, I hope I did not bore with.
Thank you, sir. Naresh, sir, I have to say it was an extremely practical but very important tips which you've given us. And it's not just the surgeons, but I think a lot of anesthetists are also doing that. We are giving transfusions, platelets left, right, center with 50, 50 platelets. It's happening all around. But it was informative, and we would there are a lot of questions coming, so we would be taking all of them towards the end.
Yeah, definitely. Thank you.
Thank you, sir. Next, I would request Dr. Prakash Dev. So if you're ready with your presentation, we would like to listen to you.
Thank you. I'd like to share my screen now.
Yes.
So am I visible and audible?
But not maximized. The screen is not maxed.
Just make it full screen.
Okay. Just a second.
Yeah.
Is this visible and audible now?
Yes, yes, yes.
Okay.
It's full screen as well. Yeah.
Okay. So should I start now?
Yes, sir, please.
Okay. So I'd like to thank ISA for giving me this opportunity to talk in front of so many experienced anesthesiologists and senior people. And my speakers, both of them, I think, have covered most of the things. So I'd just like to talk a few things about the evidence-based comparison of different types of fluids in the perioperative period, so that it helps cracking those dilemmas, which type of fluid would be more appropriate in the perioperative period. So in perioperative period, there are not much large trials. Numerous small trials are there which have compared different types of patient populations from different types of major surgeries like urological, gynecological, or abdominal or vascular surgeries. And they have compared balanced crystalloid solution with the saline solutions in all these trials. So two things have come up in common. One is that the saline group had a higher incidence of hyperchloremic acidosis, and the balanced crystalloids had lesser incidence of early acute kidney injury biomarkers. So as such, saline infusion is expected to cause hyperchloremic acidosis and is expected to have multiple deleterious physiological effects. However, and these effects are expected to be in the form of renal vasoconstriction, or it may be reduced GFR, or it may cause some GI discomfort. However, what meta-analysis on the perioperative fluids, they have shown that this acid-base abnormalities in the saline group is usually cleared like within maximum by second post-operative day, and at the same time there was no difference in the acute kidney injury markers and the requirement of renal replacement therapy and other features between the saline group and the valence crystalloid group. The largest trial till now that has been done in the perioperative period is LICRA trial, where they have compared low chloride solutions with the high chloride solutions in cardiac surgery patients. They have enrolled around 1,136 adults, and in this LICRA trial also, they did not find a significant difference between the AKI rates between these two groups. However, there are some limitations in terms of using heterogeneous groups in terms of pre-existing disease, which can actually raise the kidney injury. So unlike perioperative period, where we don't find much of the evidences between the two groups, most of the results and the differences in the outcomes between the balanced group and the saline group has come up in critically ill patients or septic patients and the patients who have been admitted in emergency and ICU. Some of the remarkable trials like split trials, SALT trials, SALTED trials, SMART trials. So all these have assessed the major advanced cardiac kidney events within 30 days and in hospital mortality. So all these have favored the use of balanced crystalloids over saline solution. And two ongoing trials like basic study and plus is going on. So they may put some more lights into this controversy. Though these studies which have been done in the critical patients cannot be correlated directly with the perioperative setting, because the physiological status of the patients who are going into the operation room will be different from the critical care patients. So, and at the same time, there will be some sick patients also, maybe some septic patients, some patients may be at risk of acute kidney injury. So a cautious approach for saline administration should be there during perioperative period. Compared to the balanced crystalloid solution, saline solution causes delayed diuresis. That is, the unloading of sodium and water may take many days from the body to wash off. And so we have to be very careful when we are treating patients like hepatic failure or heart failure. And if we have seen that in a healthy adult, if you give a very rapid volume of saline, they may cause some GI discomfort. And unlike balanced crystalloid solutions, saline induced extracellular fluid expansion, and that remains prolonged for a quite long period. So in addition to other side effects, I mean ill effects of the saline, we can conclude that we can use saline, but we have to use it very judiciously and selected cases. We should avoid using saline in large volume and rapidly. And it has to be mentioned that in some particular cases where maintaining the sodium concentration is very essential, like in cerebral edema, we have to use saline. However, nowadays people are using isotonic valent solution over NS to avoid the side effects of NS and at the same time maintaining the sodium chloride solution. And advantage is that they have they are isotonic compared to RL, which is slightly hypotonic. And there are some other indications like gastric outlet obstruction, where or in intractable vomiting, where overall total body sodium and chloride is depleted. So in those cases, you can use saline solution easily. And but you have to keep in mind that acute severe this hyponatremia, which is symptomatic, so it should not be treated with a normal saline, rather you should use hypertonic saline. And in some patients like raised intracranial pressure, it is essential to maintain the plasma osmolarity. And in those cases, we can use like hypertonic saline 3% to maintain the plasma osmolarity. So another controversial thing in the perioperative period is the choice of fluid like crystalloid versus colloid. So what we know traditionally is that IV fluids are filtered throughout the capillary end, and they're evenly distributed in the extracellular fluid compartment. And 1/4 to 1/5 of the infused intravascular volume ultimately remains in the circulation after 20 minutes. So it is less helpful in plasma volume expansion. And colloids remain in the intravascular space for a prolonged period of time, and it may help to reduce the edema, like pulmonary edema, cerebral edema, as Dr. Naresh was mentioning. But recently, we have seen the concept of endothelial glycocalyx, and the subendothelial glycocalycial layer has come up, and this layer have immense capability to hold protein poor fluid, so they can hold around 700 to 1 liter of fluid. And this concept has actually revolutionized the way we look into the transpulmonary pressure, transpulmonary flow of the blood. So you can see here is the revised Starling equation, where you can see that the interstitial oncotic pressure has been replaced by the glycocalycial oncotic pressure. So we'll come into the implications later on. So similarly, like we have seen the data in the perioperative critical care patients between when we compared wellness solution and isotonic solution. Similarly, there are many trials where they have compared the colloid with the saline solution in critical care patients. And there are two different types of trials. One type of trials where they have used hydroxyethyl starch as colloid and found a higher incidence of AKI and requirement of renal replacement therapy. And some trials like Crystal and Christmas Pile, they did not find much differences. One important thing about the studies is that they have used starch and they have compared with saline, and both of them is harmful to the kidney. So lot of controversies around the use of colloid versus crystalloid in critical setups. So the European Society of Intensive Care Medicine has recommended against using 6% hydroxyethyl starch in severe sepsis patients, and those patients who are at risk of acute kidney injury. Similarly, US FDA and European Medical Agency, they have put this under black box. So I'm just talking about the critical care patients because data are more robust in that field. Now, if we talk about the operating room setup, gelatin is an excellent choice, which is extensively being used in Europe, but not in USA. And I have also been using it for a quite long period of time. The advantage is that it has less effect on the coagulation. If you use in surgeries where there are lot of blood loss is going on, it will be helpful, and it is excreted mostly by the kidney. Some reports of anaphylaxis there. I think amongst the colloids, it is considered to be the colloid which has highest incidence of anaphylaxis. Some people they use some test dose and they start a very slow infusion to check if there is any anaphylaxis is happening or not, and then they start with a higher flow. But I don't know if it is supported by any evidence or not. And if we come to albumin as a colloid in the operating room, 5% albumin has a nice physiological colloid oncotic pressure of around 20 mmHg, and it can be used for volume expansion in the operative room. If we consider critically ill patients, there was a safe trial and which found no significant difference in the outcomes in critically ill patients. And sepsis, in fact, if we use albumin, it has been found to decrease the frequency of mortality. However, in traumatic brain injury in neuro patients, the albumin infusion has been found to be associated with increased mortality. So it preferably should be avoided. So if we look at the plasma effect on the plasma volume, so during operation, large amount of blood loss has happened and we have to expand the plasma volume. So it has been traditionally said that around 20% remains in the circulation. So we have come up with the new requirement of crystalloid to expand the plasma volume, which is around 1.5:1. So 40 to 45% more crystalloids are required compared to colloid when we have to expand the volume. This volume is much lesser than the earlier we used to think and we used to administer, but this amount is sufficiently large to cause edema in the compliant tissues. Like if you are doing GI surgeries and those surgeries where there is chances of edema which is going to hamper the post-operative recovery, then you have to be very careful using those crystalloids for plasma volume expansion. So in perioperative use, we can say that we have a very limited data, and whatever we use like in maintenance replacement, well and crystalloid is a good solution. Recently, on meta-analysis, they have shown that hydroxyethyl starch, if you use in the intraoperative period, it is not even associated with higher risk of mortality or AKI, unlike critically ill patients where data is conflicting. So the question is that whether we can use colloid. Yes, we can use colloid, but we have to be careful because if we use, we have to balance the risk. If we use crystalloid, there are chances of tissue edema, and at times there may not be able to achieve those hemodynamic stability which a colloid would achieve. So there may be some impairment of the organ perfusion. So this has to be balanced with the possible ill effects of the colloid, which may happen in selected and susceptible patients. So there are some factors which need to be considered while choosing a fluid. One is the preoperative status. So patient coming to the operation theater may be having already an existing acid-base balance or fluid balance. So that has to be taken into consideration while choosing the fluid. The different phases of the surgery. So how much fluid and what fluid has to be used in the pre-op period, in the intra-op period, and the post-op period has to be adjusted accordingly. Patient comorbidity is very important. So patients with kidney disease, patients with heart disease, patient with liver failure, patient with having preeclampsia. So choice of fluid should be dependent and guided by the patient's disease condition. And sometimes these patients are having different types of drugs for their primary disease. So that has also to be considered whether it is actually hampering the acid base and electrolyte balance. Like patient may be on diuretics, and this surgical procedure, which we know is one of the most important factors. So depending upon the type of surgery, whether it's a neurosurgery, whether it's a cardiac surgery, thoracic surgery, abdominal surgery, so flap surgery, so we have to consider accordingly. And obviously the type of liver and restriction and the goal directed therapy we have already discussed. So what we can conclude is that there are some general laws because there is lack of robust data in the perioperative period. So it should be mostly an anesthetist decision based on the knowledge of risks with a particular fluid and the benefit of administering that fluid in a particular patient and surgery. So it has to be decided in a case-to-case basis rather than following a strict rule. So it has to be indication based and it has to be individualized and has to depend on the patient comorbidity and the surgery. One important point is that the choice of fluid, not only the volume, the choice of fluid is also should change based on the assessment of the electrolytes and fluid and the clinical features interoperatively. So with these words, I'll finish. Thank you so much for patient listening.
Thanks a lot, Dr. Prakash Dev. It was an extremely good presentation, very, very practical. Again, I would like to say. So basically, you've removed this concept that contraindicated completely, right? So thank you. I would request Dr. Kalyani ma'am to please take this further from here. And then we would come back to the questions.
Yeah, so yeah. Should we just discuss the cases which I shared? Dr. Prakash Dev, can you just give your opinions
so
on the...
One question I have seen here is that they're asking about the third space, first space, and second space.
No, sir, just a minute.
Which one?
We can just discuss the cases which I shared. We'll just have a brief discussion on that, and then we'll take up the questions from the chat box.
Can you just ask this question?
Yeah, so first was basically a patient of traumatic brain injury with a significant midline shift and with a impending herniation.
Okay,
for decompressive craniotomy.
Okay, fine. So the question is that when we talk about such patients which is coming to the emergency, means the patient has come with a depressed GCS, means the ICP is expected to be high. So it is recommended the first priority should be to reduce the ICP as much as possible with the help of medical attention till the patient is planned for the surgery. So we can use mannitol, we can use hypertonic saline, and this debate is going on and on. And the primary target should be maintaining a proper cerebral perfusion pressure irrespective of what type of fluid is used, number one. Number two is that we have to maintain the osmolality and we have to maintain the sodium concentration at the same time. So when we think about the maintaining the cerebral perfusion pressure, it has been seen that in most of the trials, we have seen that using colloid may cause this and that type of acute kidney injury, this type of patients. But in traumatic brain injury patients, if a patient comes with ischemic brain injury and if you resuscitate for some time with a colloid other than albumin like hydroxyethyl starch, then if you can improve the CPP, it has to be balanced that the risk of AKI. So this is one point. Another thing is that like subarachnoid hemorrhage, earlier we used to follow this triple H therapy. So it has been seen in different trials that if you use hydroxyethyl starch or other colloids and improve CPP, it actually delays the cerebral ischemia secondary to vasospasm. So it is very much essential to maintain the cerebral perfusion pressure. So in this case, we can see that we should start with the hypertonic saline and you can use the mannitol, and you should start reducing this. And for maintenance, you can use a normal saline rather than Ringer's lactate, which is a sodium content slightly lower than this and considered to be hypotonic. So preferably, you should go in that way.
Sir, I have a question. What if there is no hypertonic saline available? A lot of places don't have hypertonic saline. Then what do you use next?
I think Dr. Himangi Karnik madam can answer it.
Yeah.
Stop sharing the screen. Dr.
Yes, ma'am. Yeah.
No, it's okay. You can continue sharing and we can talk. No problems. One thing, hypertonic saline definitely has an upper hand in this type of situations because with a very small volume, it can increase the intravascular circulating volume as well as it can cause the cerebral dehydration. So that is definitely advantageous and it is not very costly. So we can easily keep it available. In fact, it is recommended for the pre-hospital scenario also. So that is one thing that is useful. As far as the other, if it is not available, as far as the other fluids are concerned, the crystalloids are our first choice. So this patient not only has cerebral edema or those possibility because of the associated contusions that may have this patient have. They also, the scalp is a highly vascular structure, so patient might have bled externally also. So for that, we require the fluid resuscitation, and amongst all the crystalloids, normal saline should be the starting point for starting. As far as a difference between all these crystalloids are concerned, normal saline increases the blood volume a little bit higher than the other balanced salt solution as compared to ringer lactate or plasmalite or anything, about 10% higher. The others are less effective. So the first choice probably would be the normal saline for resuscitation, and if hypertonic saline is not available. And later on, then we can go on to the Rose concept and all those things later on.
Okay, yeah. Thank you so much, ma'am. So can I just request Dr. Lakshmi Kumar ma'am to enlighten us about the second case, which was an exploratory laparotomy with acidosis and sepsis.
Yeah. Essentially you are having an abdominal surgery, and here patient has had some hypoperfusion with raised lactates.
Yes.
So the lactate can be just because of tissue hypoperfusion, or it can be due to hepatic ischemia and inability of the liver to metabolize lactate. So in this situation, if you were to use lactates as a marker of recovery from hypoperfusion, may be prudent to use a plasma light solution rather than a ringer lactate solution. Okay. So that would be perhaps when it is available, that is the fluid I would like to use.
Okay. Yeah. Thank you so much, ma'am. So there was a question regarding the same condition in the chat box also. So I think we've answered that. So now we'll just move on to the next questions in the chat box. So one of the pertinent questions which has been asked is, what is the first and second space with respect to the third space, I guess?
So, should I answer that?
Yes, sir, sure. I think you were about to answer it. Yeah.
So but actually, I have never read about it, but what I heard, the first space and the second space, they corresponds to the intravascular fluid, and then interstitial intracellular fluid combined. Okay. And the third space refers to the bowel lumen, and like in case of pancreatitis, it may be retroperitoneal space also. So the choice of fluid, I think they have asked, so it should be like more physiological to the body because it is a physiological fluid. So it should be a balanced crystalloid solution.
Okay, so there is another question related to it, that fluid management intraoperatively for third space losses, like ascitic fluid loss. How do we replace that intraoperatively? So that is what I mentioned. Like one thing is volume and another is the type of fluid. So type of fluid should be guided. I mean, a proper balanced solution, maybe isotonic balanced solution, or maybe like Ringer's lactate also we can use. But if the patient is having too much of loss of protein or albumin from such tissues, which actually leading to hypoalbuminemia, that time maybe we can resuscitate. If the patient is crashing, then you can resuscitate with the 5% albumin solution, which you can usually prepare from 20% albumin so
easily.
It will also depend on the type of fluid that is
type of fluid and the acuity and how severe it is. So.
Yes.
Dr. Kalyani, there's one question there in the chat box. So I would like to ask this question to Dr. Lakshmi, ma'am. Ma'am, could you just tell us after how much time we should review the adequacy of fluid replacement?
So are you talking with specifics to this case that is discussed?
No,
or
that's a general question, ma'am.
It's a general question.
General question.
I think there's no time. So if you have a particular event like ascites, like I think the dictum we follow is if it's large ascites, 7 to 8 grams per liter of ascites, and you give a 25% albumin so as to avoid any re-expansion, pulmonary edema. I think the fluid assessment should be very dynamic. it happens
Yeah.
along with the changes in surgery. So by the time you have time to recover to handle a loss, then you need to know if you're adequate. So I think it's not how much time, it's very dynamic, and it only stops when any major losses are over and you're comfortable with ongoing.
Can I add? I think it
Sure,
should be
sure, sir, please.
at
Yes, sir, please go ahead.
every hourly we should keep an eye on the IV fluids calculation. Every hourly, check for the urine output, check for the parameters. It should not be more than that. Maybe early you can do it if it is a high risk patient, if it is a major surgery, but not beyond 1 hour. At least you can plan for the next hour, so that you can plan for the next hour how to replace it.
Right.
It is better to avoid a problem rather than face a problem.
Yeah.
Another question which is being
So-
constantly being repeated is, can I ask that to Dr. Himangi Karnik? Ma'am, can I ask?
The previous question?
Yeah, ma'am.
This reviewing of the patient depends
Yeah.
upon what stage of resuscitation we are, what stage of IV fluid therapy we are at. Say during the resuscitation phase, we have to continuously monitor the phase, monitor the patient, and check the macro, check the status of the macro circulation, that is the heart rate, blood pressure, and all those things. Later on, in the ROSE concept, that later on, there is an optimization phase, then comes the stabilization phase, and then active evacuation phase if patient is hypervolemic and all. So here, the reviewing become less frequent, however important, and there we check the adequacy of the microcirculation as well, and when to stop giving the additional fluid and all those things. That needs to be done. So reviewing and frequency both changes as per the its severity and time phase of the patient's IV fluid therapy. Not only that, whether the patient has got additional continuous loss or no, that also needs to be reviewed along with that.
Yes.
Yes,
Okay.
agree.
So, ma'am, regarding the microcirculatory assessment, you mean to say that in the optimization and stabilization phase also do we go for the microcirculatory parameters, or it is just till the patient is stabilized we go for them? And
optimization probably we may not, but for the optimization, if you want to see the different organ perfusion, probably
maybe with the
to see the end stage of the optimization, adequacy of the fluid therapy, probably.
Once maybe the patient goes in the stabilization phase of ROSE, we may just go according to the clinical parameters instead of going for the okay. Yeah.
At least for 24 hours, hours, be vigilant. At least even after stabilization, for 24 hours is important.
Kalyani ma'am, there's another 2-3 repeated questions which I would like to ask Dr. Himangi. Can I please?
Yeah, sure.
Dr. Himangi, basically a lot of questions are coming on what are the basic parameters on covering fasting and maintenance fluids in any adult patient. Say if there's a lap chole and a patient is 6 hours fasting, so how do we go about it?
6 hours fasting is an older guideline, and 6 hours starving for solid foods is the older guidelines. We still follow that for solid foods. However, the guidelines for the oral clear liquids have changed in the last almost 6-7 years. It is recommended that the patient gets clear fluids up to 2 hours before the surgery, and clear means really clear. It doesn't mean that pani pine ko bola to chai pee li, that thing should not happen. It should be clear fluid. It may contain carbohydrate, especially maltodextrin containing carbohydrates have been recommended. It has been used in situations like neurosurgical cases also safely, so that can be given to anybody, but it should be a non-particulate clear fluids, even for adults, diabetics, as well as for pediatric patients. So no need to starve for more than 2 hours for clear liquids.
And do you routinely give maltodextrin to your patients?
It has been given in various studies, but routinely we give clear fluids.
clear
not,
fluids.
no.
Yeah, I think there was a
So
question
I think
regarding
especially in
May I-
diabetics, yeah.
May I add a point to that?
Yeah, yeah.
Okay, so I totally agree with Himangi ma'am that this fasting guidelines says that the fasting period should be as minimum as possible, and preferably 2 hours prior to surgery. I mean, you should have a gap of 2 hours, and you can give some carbohydrate containing. So ERA's guidelines is specifically asking for using that, and this carbohydrates around 80 grams of glucose. If
Complex
you give that
carbohydrates.
reduces the catabolism post-operatively also and improves the recovery and healing. So we have been using for like onco cases like
Yeah.
APPs, which is actually non-pulp containing, and it has carbohydrate content of
Okay.
100 ml contains around that level. So you can use that, and we have to be careful that sometimes patients use a pulp containing fluid. So we have to be very careful. So we have adequate understanding that the patient attendants are actually getting what we are trying to say. Otherwise, it
Yeah.
will be a risky thing.
And the carbohydrate containing fluids also reduce the insulin resistance, especially in
Yes.
diabetics, which we
Correct.
commonly encounter in the post-operative period. Yeah. There are many questions on the related to platelet counts. So one is the minimal platelet count for minimal, moderate, and major elective surgery. Like this must be pertaining to whether transfusion should be given or not, or at what threshold should we consider transfusion. So Dr. Lakshmi Kumar ma'am, can you just discuss this? Yeah.
Yeah, you don't really have to follow an absolute number, but there are guidelines that say that for surgery, you need to have a minimum of 50,000 platelets. And any patient with a platelet count below 20,000 has a risk of spontaneous intracerebral bleed. So I work in a liver unit. We do liver patients day and day out. And apart from the transplant recipients, if the plate, I mean, we are probably a little generous with them. I would take in a patient with a platelet of 35, 40,000. But otherwise, a non-transplant patient, when they come for surgery in child C or something, most of the surgeons would want some form of platelet given for, say, something like an umbilical hernia. So they would want, because they're worried about a bleed and a hematoma along the line of incision. Even if you say, I'm going to give a rectus sheath block and I'm not worried. But even when you give a rectus sheath block, you need to be cautious that you don't injure a vessel. So there are guidelines, even in child C, coming for non-transplant surgery. Most surgeons would want to be around 50. And if somebody is very resistant to correction, then using a TEG and finding a normal value of the TEG and a rotum may give you some comfort, but I can bet most surgeons won't put a knife with a platelet lower than that.
Yeah.
And for less than 20, even any anesthetic procedure, we would want to transfuse platelets because they have a risk of spontaneous intracranial bleed. And at 20, I would definitely give platelets either just along with or just before and take the patient.
So, ma'am, how much do you anticipate the rise and by what time does it rise?
They
Practically?
say SDP, that if unit of platelets or 1 unit of pooled platelets, you expect a rise between 40 to 50,000 and 1 unit of random donor platelets, the RDP and the SDP. That is what they talk about. The RDP can raise the platelet count by between 8 to 10,000. So most patients with cirrhosis, they have some kind of destruction of the platelets. So this may not really translate into these numbers, but you know you've done your bit when you take the patient. And I agree, many of them don't bleed, but we are cautious.
So even if we transfuse them immediately pre-op, it does help.
Transfuse an hour before, sometimes along with putting the IV line. The volumes are not very high. So they are finished within 10 minutes.
Yes,
and then
and regarding neuraxial blocks in a patient with chronic liver disease, is there any cutoff?
Up to child, they say in child A you can give. In child B, we look at the risks and the so up to child B, like if you have a child B with multiple other problems coming for prostate, then a senior would put a spinal. But anything higher grades of child B and never in child C, and with so much ultrasound guided blocks, we have so many other things to do besides.
And it's not just the platelet count in chronic liver disease, which
Ma'am, I would like to ask that even if the platelet count is 45,000, we will still give it even if it is child A?
a child A usually will not have a platelet count of 45.
Yeah,
It's
exactly.
Yeah, right. Yeah.
likely to have extreme portal hypertension. And
Yeah,
again, it can be what kind of surgery is he coming for.
Mhm.
Even if a child, you call, let's say for your argument, a child A does have a platelet of 45, he's coming for lap surgery. I might give 1 or 2 units of RDP and do the surgery because to me, the victim still is have a platelet count of 50.
But would you give a neuraxial block in that patient?
55,000, it's unlikely he's child A. It means there is substantial portal hypertension to reduce his platelets.
But under that platelet cover, are we justified in giving a neuraxial block?
No, never.
Yeah,
Never.
yeah.
Never. Never below
Yeah.
platelet. 50.
Yeah.
50
So
is the
yes,
cutoff.
yes.
Above
Yeah.
50 we would give.
Yeah. And ma'am, there was a conversation in the chat box, like
Can I add
whether
to that? Can I
yes,
add
ma'am,
to
sure,
that?
sure, ma'am, sure,
Not
ma'am.
only the absolute platelet count is important, it is also needs to be collaborated with the clinical condition of the patient,
Yes,
whether
yeah.
patient is bleeding actively or no, and whether the surgery is ongoing and all that needs to be seen. Besides that, even if the patient surgery is not going on, perioperative patient, ICU patient, we need to see the trend of the platelet count. Like many of the head injury patients, we have gradually decreasing platelet
Drop
counts
in
and
the-
all. So is there any consumption coagulopathy which is going to worsen the condition or no? That will need to be found out so that we can decide upon whether to replace the platelets or not. The transfusion is needed to be given up.
Yeah, yeah.
Himangi ma'am, in the same thing, could you please tell the platelet cutoff for neurosurgical cases? There's a question in the chat box.
There are different opinions about it. Some take it as 80,000, some take it as 1 lakh. And requirement is much higher because the consequences of uncontrolled bleeding are much higher. So we recently had several patients with the lower platelet counts having multiple issues and patients coming for again and again resurgeries and all with the lower thing. And this head injury and gradually decreasing platelet count, especially in contusion patients and STH patients, is a very major issue. So that needs to be seen. They don't require much platelet transfusion per se, but you need to plan your anesthesia and all. And if the count is below 50,000, definitely they will require.
Okay. Yeah.
May I add a point?
Can I add? Yes, yes.
Okay, please, Dr. Naresh.
Okay. The neurosurgeon will not put a knife less than 1 lakh. They need 1 lakh plus, and that too with the backup of platelets. They will never put.
No, it all depends on the clinical situation.
Yeah,
How is the
quite often
patient?
they don't have a choice.
Yeah, they don't
Yeah.
give. Yeah.
It
You
just
have
keep
to go
bleeding
ahead.
without
Yes.
place.
Yes.
So, may I add a point here?
Yes, Dr. Dev.
Okay, so I have seen a lot of questions regarding the platelet level and whether it is safe to do the procedures or not. So as both Lakshmi ma'am and Himangi ma'am has said, it is not only the numbers, it's actually the clinical feature scenario and the perspective when you are going to transpose. So it is a cumulative clinical decision rather than a fixed number. If you want to, if the anesthetist like PG students, maybe they are willing to know the numbers. So it is strictly said that if a patient is asymptomatic, not having anything, just staying like that, like in bone marrow transplant patient or someone is having chemotherapy induced bone marrow suppression, then the count around 10,000, 5,000 is also okay for not doing any procedure. Just like they need not treat it. If the patient is undergoing minor procedure, maybe in the form of bone marrow aspiration or intrathecal some drugs, then we can at least elevate it up to 20,000. If we are going for some procedures like vaginal delivery or something, it can go up to 50,000. If we want to give LSCS in a pregnancy patient, so absolute value what is recommended is around 80,000. In neurosurgical patient, it's around 1 lakh. So if you really want to know the values, so values go like this, if I'm not wrong.
Okay. Yeah.
Are
So,
there
ma'am,
any questions?
Yeah, ma'am. Just one thing which we have not covered. Yeah. So there's one question regarding management of diabetic ketoacidosis. There was a conversation in the chat blocks which mentioned that it was answered that balanced salt solutions are preferred over normal saline even in DKA. So Dr. Himangi Karnik ma'am, can you just clear this concept? Like what is the current recommendation, whether it is normal saline for the initial resuscitation or it's balanced salt solutions are preferred?
I'm not sure about the very recent guidelines about the diabetic ketoacidosis. However, both saline as well as the balanced salt solutions, both have been used and both are found to be satisfactory. a little difference between when the comparison between the crystalloid versus crystalloid is concerned. Normal saline is associated with little lesser renal blood flow. And as Dr. Prakash had mentioned about the smart split study and salted study and all those things, even though the outcome is not changing, there is some difference in the renal blood flow. So little bit advantage is there as far as the balanced salt solutions is concerned. But however, there are not much evidence probably for the ketoacidotic patients per se. So you can definitely say this is good or bad. Dr. Prakash, you would like to add anything?
Yes, sir.
Yes, ma'am. Ma'am, what we practice, like what is actually recommended to practice in an acute patient who is coming with diabetic ketoacidosis. So every 100 mg% increase in glucose, there is 2 milliequivalent decrease in the sodium. So it is always preferable to use normal saline as the first solution. So patient should be loaded with this solution. So subsequently patient goes in phases where the potassium count goes down, because we are also giving insulin. So there will be intracellular migration of the potassium. So the patient will pass through some stages where the potassium will also be low. So in those cases, we can use a balanced solution also, alternating with the NS. And likewise, as we know that the rapid and as you also mentioned, rapid and large volume of NS can cause those metabolic derangements. And subsequently, like a phase, initially patient will come with a stage when actually the because of acidosis, the potassium content is high. So we should refrain ourselves from using NS at the first go, RL at the first go, or other potassium containing fluids, and later on we can titrate accordingly. Anyways, we are doing repeated ABGs in such patients, so we can make our assessments accordingly based on those.
So should we just, if
you
you've
so
taken
much,
all the
sir.
questions, should we just close the session, ma'am?
I think we'll
May I
hand it
make
over
one comment?
to
And
Kartika.
Dr.
Yes, ma'am.
Anisha?
Yes. Yeah. Dr.
if all
Karnik
the
ma'am
que-
has one.
May
And
I
I
make
think
a
him.
comment?
Yeah. Yes, ma'am. Yeah.
No, we have not talked about much about colloid versus colloid. So I just wanted to say that all colloids are not same. In the same vein, all starches are also not same. So the side effects and problems and complications that we have heard about in different studies and all are common to all the colloids, like said, but each individual colloid behaves differently and acts differently. Those who are the younger population probably may not know that the earlier colloids on which the maximum studies and results are there were the heta starches, which were associated with the higher volume expansion, prolonged action, as well as more common side effects like effect on coagulation as well as on the renal effects. Whereas the recent newer starches that are now only tetra starches available, Volu-N and Volu-Lite both, are associated with the lesser complications and all, shorter duration of action, and minimal effect on the coagulation. So while choosing your colloid, also choose wisely.
Thank you so much.
Right. Actually, there are a lot of repetition questions, Dr. Kalyani. So would we want to just
I think
close
we
it?
have covered most of them, I guess.
Most of it, right?
We have
I think
covered all
we'll
the
hand it
questions.
over to Dr. Manisha ma'am. Yeah.
Lakshmi madam, would you like to add something about this?
No, I think this controversy can go on. So if you have specific questions, they can put it up in the group. I'd be
There's just one suggestion that IJ should have an addition on perioperative fluid. So I think that should be considered.
Hello.
Yes. Yes, Dr. Pawar. Yes.
Hello.
Yes, Dr. Pawar.
Yes, madam. What about the post-operative fluid management in a pediatric patient, madam? Is there a role of isolate P that fluid? No, most of the pediatricians or pediatric surgeons, they advise this isolate P in the post-operative period.
I think now many of them would not be given isolate P because of the awareness that hypotonic solutions can lead to convulsions. So it's either a balanced salt solution, or some pediatricians still use normal saline, pediatric surgeons, because we write the order with the ringer lactate. So it varies between ringer lactate, sometimes half normal saline, sometimes normal saline, but never isolate P, because the sodium in isolate P is very, very low.
Thank you.
So if there are no questions, it was like I would like to sum up for today's session. It was definitely an excellent session, very practical presentation by Dr. Raksha as well as Dr. Naresh Anand, and excellent presentation with evidence-based learning from Dr. Prakash Dev. It was really wonderful learning from both the chairpersons, Dr. Lakshmi Kumar and Dr. Himangi Karnik. And definitely, we today, all of us learned the most important thing: give the right fluid to the right patient in the right dose and at the right time in the right clinical scenario. So, Dr. Bajwa, can you take the proceedings further?
Thank you, Dr. Manisha. Today I was feeling like a student only. I was listening to everything, whatever was said. As Dr. Karnik Madam said in the beginning that we have volume 2, volume 3 also of this discussion. That will also come up very soon. But I think this topic cannot be covered in 1.5 to 2 hours also. If the discussion keeps on going for 5 hours, I think it will not stop. Few of the questions have still remained unanswered, doubtful basically. Those will be cleared with evidence-based support and experience-based support also. Those will definitely come into discussion with the next, I think very soon, maybe 2-3 months, we will have another session on these type of things, almost similar to this one. The idea basically is to involve the audience here. It's not of just giving a lectures here. It's the audience today got involved like anything. And the questions, all the questions being answered by our moderator, the chairperson, it was excellent. They have a very good energy. And the way everything was handled with all the maturity and precision, many of the answers got very well. I think more than what they answered, more than what was required also, and that I think added to the knowledge of and wisdom of everyone who was attending this session. And the idea was to have a good interactive session, and that we are successful in that. And future also we will be helping the other of our audience to get involved into these types of discussions. Wonderful session to our panelists, our speakers, as well as the facilitators. Both they were also having a eagle eye on the chat box and breaking up every questions. And
Yes.
I'm really indebted to all of you who have contributed this thing for our ISA academics. We are definitely getting enriched by your presence, knowledge, and wisdom, and definitely a good interactive session. Well enjoyed, thoroughly enjoyed, and enlightened us to some many new facts. So, Dr. Manisha, I think that is good enough from my side, and we cannot thank you more than that.
Can we have the certificates?
I will just take it out. Just wait for one.
Yeah.
Give me 1 minute only. In the meanwhile, you can continue with the discussion also.
So I'll utilize this time to thank all the chairpersons and my co-panelists. They were wonderful. Thank you, Lakshmi ma'am. Thank you, Mangi ma'am, and Dr. Kalyani and Dr. Meena. It was very nice.
Thank you so
with
much,
all
ma'am.
of you.
Thank you, ma'am. Thank
Thank
you.
you, ma'am.
Thank you to all the speakers who've taken the effort and put in different concepts and perspectives. Thank you.
All 3 presentations were good, excellent, and really I am honored and happy to be part of this program. Thank you, I say.
And
I may
Manisha
not
ma'am,
be-
also thank you. She was taking all the efforts from the beginning, and she was very enthused about this class.
Yeah.
Yes.
Dr.
I'd also
Manisha.
like to thank Bajwa sir, Manisha ma'am, Manoj sir, and all the moderators and chairperson, and also the speakers, and for giving me this opportunity, this platform to present. And also I gained a lot of knowledge today. I'd like to thank specifically Himangi ma'am. I don't know if madam recognizes me or not. I was there in Sion for 1 month, and I was your student there, 2015. So special thanks to you, ma'am.
Remember that when I said I heard Tata Memorial Hospital, I realized that.
Thank you, ma'am. It's been a long time.
Dr. Manisha, certificates are visible.
Yes, yes.
Yes, yes.
You have to make it full screen.
Raksha, your
Full screen.
certificate.
Make it full screen, sir.
Thank you. Thank you
I
so
think
much.
I won't be able to make. There are certain
Okay.
things are also
Okay.
going on.
Okay. Yeah.
Dr. Naresh, your certificate. Dr. Naresh is there or not?
Yeah.
You're not
Okay.
able to move. The
Yes, sir.
slides are
Yes,
not
sir.
moving.
I am there. I am there, sir.
Dr. Naresh certificate not visible.
Not
No,
visible.
sir,
Certificate
moving.
is
It's
not
not
visible.
moving to the
एक
next
मिनट,
slides.
continue.
Okay. Let me see.
Sir, ये print out निकालना certificate का? How we take it out?
You will get an email.
हाँ, by an email. Okay.
Yeah.
We will be sending through email also.
अच्छा जी. अच्छा sir. ठीक है.
Somebody's asking in the chat box.
Yeah.
for
Participant certificate. Yeah.
Participant certificate.
That can be given only if they would have
Auntie,
attended the
hold
entire
करेगा.
session. The next time we can do that.
Yeah.
ठीक है आंटी.
Actually, the computer work was going on simultaneously. There are certain things. I'm
But
not
thanks
able
to Dr. Bajwa and Dr. Manisha and everybody here. Thank you firstly for, having me here as a moderator. And it was ma'am was, with us for the past 4 days, continuously giving us all the instructions. And thank you, Dr. Kalyani, for the slides and everything. Thank you so much.
Thanks, Meenal, for being a co-moderator, and thanks to Bajwa sir and Katikar ma'am. Ma'am was really, her energy is like contagious.
Very infectious.
Thank you, ma'am.
True.
Can we leave?
Let's see if the other.
I think now it's visible.
Yes, yes.
Yes, sir.
Yeah,
Yes,
yeah.
sir. Yes,
Dr.
sir.
Naresh Anand's visible, na?
हाँ जी सर.
Yes.
हाँ जी दिख रहा है सर. दिख रहा है.
Okay, okay, okay. See, let me see the next one. Dr.
Yes,
Prakash
sir.
Tip.
Yes, sir, visible, sir.
Okay. Dr. Lakshmi Kumar ma'am, your name is correct here. Yeah. Dr. Hemangi Karnik madam.
Thank you.
Dr. Meenal Chauhan, your certificate.
Yes, sir. Thank
And
you.
Dr. Kalyani Patel, your certificate.
Thank you, sir. Thank you. Thank you so
These
much.
will also go to your email also. We will be sending them very shortly.
Thanks a lot.
Dr. Manisha, back to you.
Yeah. I request our treasurer, ISA National, Dr. Manoj Kumar sir, for a word and then vote of thanks.
Good evening, everyone, to one and all present here. It is such an honor for me to get the opportunity to give vote of thanks. I extend my gratitude to our visionary ISA National President, Dr. M.V. Bhimeshwar sir, for his guidance, support, and blessings. I would like to thanks to our dynamic ISA National Secretary, Dr. Sukhvinder Jeet Singh Bajwa, for his day and night hard work, which can lead to our ISA flag is flying high. I would express my sincere gratitude to the today's webinar moderator, Dr. Lakshmi Kumar Madam and Dr. Himangi Karnik Madam. They enlightened all of us with innovative ideas on perioperative fluid therapy. Thank you so much to Dr. Lakshmi Kumar Madam and Dr. Himangi Karnik Madam, and heads off to both of you, ma'am. I would like to thanks to all the speakers of today's CRISP series on perioperative fluid therapy, Dr. Raksha Kundal Madam, Dr. Naresh Anand sir, and Dr. Prakash Dev sir. You all have delivered excellent presentation and answered all the questions in a nice way from which all the members have got benefited. Thank you so much to all speakers of the today's webinar. My sincere thanks to academic moderator, Dr. Meenal Chauhan, Madam, and Dr. Kalyani Patil, Madam, for excellent conduction of the CRISP Series 5. Thank you to both of you, ma'am.
Thank you, sir.
Thank you, sir.
I would like
Thanks.
to thanks to my other program head, Dr. Chintala Kisan sir, and especially Dr. Manisha Katikar, Madam, for their hard work in the conduction of this CRISP series. I thanks to all the teachers present here, faculty, and the postgraduate student who gave their valuable feedback and participated in this webinar. Thank you once again to all of you. Long live ISA. Thank you. Over to Manisha, Madam.
I think it's time to say goodbye to all of you and good night. Let's say that by saying, long live ISA.
Long live
live
ISA.
ISA. Yes.
Yes.
Good night, everyone.
Thank you.
Good night,
Good
sir.
night.